Good morning, good afternoon, and good evening to everyone from all parts of the world who have joined today for the great event happening. Happy New Year to everyone, and hope you and your family are doing safe in this COVID times. Our best wishes are with all of you. Today, we are starting with first event of the year, and what is icing to the cake with a great topic. The half-day virtual event happening today will focus on AI and healthcare. Along with six great talks, we have a power packed panel discussion too, which will add a flavor and also provide you deep insight into how AI will revolutionize the future of healthcare. Also, there's another webinar coming this month on January 25th, themed around how AI and robotics are transforming the future of healthcare. We had sent details of the event along with the joining link to everyone who have registered for the same. So do not miss to attend that too. Now, to begin with, let me introduce myself and the company to you. So, my name is Nitin Naveen, and I am the Vice President Innovation Strategy at AI CodeSpot. I'll be your host for the day. Further, I have been joined by my colleague Arvind and Naveen, who will also assist me in keeping the event lively, technical glitches if it comes in between. So, thanks a lot to them for putting in hard work and making this one a huge success. We'll try to provide a seamless experience to all of you so that you can gain maximum output. Let me provide a brief background to all of you about AI CodeSpot. We started this year backed up by our technology partner, Digit7. Our focus is to provide all of you a deep dive into all the sectors wherever technology is there. And every month the theme is different. We are gaining momentum month on month. Our aim is to be number one AI driven community all over the world so that like minded people like you can be a part of the same in supporting, growing, and making this a huge success. We'll continue to do industry backed webinars and hybrid events. All the knowledge repository will be made from industry thought leaders, subject matter experts, and thought leaders like the speakers who are presenting in our forum. We'll enrich the content through videos, blogs, podcasts, newsletters, and digital content to shed light on the ever evolving industry. Our mission is to serve as a hub for information regarding Industry 4.0 technologies, which includes AI, ML, deep learning, robotics, edge computing, analytics, 5G, drone, edge AI, digital twin, AR, VR, cloud, and so on. Today's event is one series of events which we have planned for this year. It's power-packed with speakers' presentation and panel discussion themed around how AI is transforming healthcare industry. There are more in store for subsequent months as well, with focus on banking and finance industry, retail, e-commerce, factories, supply chain, aviation, and so on. So request all of you to go through our website, aicorespot.io, for future updates. Also, please like our social media handles, which will keep you all updated on everything what we propose to offer in the coming months. Before starting with the day, I would like to highlight few things so that it can set up the tone for the amazing learning and networking day. A special mention to our technology partner, Digit7, who has helped us in understanding our vision and mission in supporting us to create a platform like this through which we can help achieve our objectives. The support is immense. So let's do some introduction about Digit7 to everyone. Innovation is the cornerstone of Digit7. At Digit7, they combine emerging technologies in unprecedented ways to engineer extraordinary products and offer innovation as a service, which is termed as INAS. They are pivoting the traditional innovation model on its head to bring innovation closer to production and citizen scale impact with innovation DNA. They draw transformative resources and endless energy from four quarters to make this happen. The association with trusted brands such as AWS, Microsoft Azure, IBM, Microsoft, SAS, Adobe, Salesforce, Sterling Commerce, amongst others, help them constantly upskill practitioners and champion the partner's best delivery methodologies. Professionally associated with tech titans, Forbes Technology Council, CompTIA, Richardson University of Dallas, Texas, and much more technology brain power. to leverage their contrasting standpoints and diverse skill sets. The products which they have are Smart Express Store, e-commerce, Grab and Go, HPOS, Admin Store Management, Smart AR, Delivery Pickup App, Digital Wallet, Drone Scan, blockchain-based supply chain management, Label Monkey, Data Mink, and Digital Twin. The services which they offer are product engineering, innovation as a service, digital transformation, customer experiences, and innovation design. You can go through their website, which is www.digit7.io, and understand more in depth about the company. Also, thanks to all our community partners for today, which includes InfoVision, Communication Service for the Deaf, OnRack, IASO, Procia, SAS, Innobot Health, Included Health, Optum Technology, Beltone, ChartNote, and Hey Rennie to make this event a success. A special mention to speakers and attendees of the event who registered and came together to achieve their objectives through this forum. At the end of the day, if you gain few things out of this or get to network with each other, our core objectives as a platform will be achieved. Further, if anybody wants to ask questions, which is a very important thing, they can type in the Q&A section, which is there at the right corner of the menu option. You can type in as and when the speaker speaks, and we'll try to get it answered after each talk or as per the time permitted. There's also a hand button at the bottom of the screen through which you can even raise the hand and come to the stage to ask questions to speakers as well. Now, I'll quickly go through the agenda and let you all get introduced to the speakers and their topics. So, yeah, this is the agenda for the day. So, we will be starting exactly in the next couple of minutes. So, we have our first speaker, who is Craig, who is Vice President of Emerging Markets Communication Service for the Deaf. And his topic is redefining accessible healthcare, direct communication for all. Then we have Len Bickman, who is Chief Artificial Intelligence Officer. His topic is using augmented intelligence at OnRack. Then we are having a great panel discussion in which the theme is how AI will revolutionize the future of healthcare. It is moderated by Chitrai Mani, CIO InfoVision. Then we have Tai, who is co-founder and CEO IASO. We have Mithul, who is VP AI Products Procia. We have Rich from SAS. He is Health Industry Executive Advisor. Then we have Natasha, who is CEO and founder of Innobot Health. And we have Jayadita Sangvi, who is Senior Director of Data Science Included Health. So they all will be great panel members in the panel discussion. Then we have a great talk by Matthew, who is the Senior Director of AI at Optum Technology. His topic is the cutting edge of artificial intelligence in healthcare. Then we have Michael Reha, who's Director of Managed Care Belton. Topic is the social and economic impact hearing loss has on consumers and health plans. Then we have Giorado, who is the founder and CEO of ChartNote. His topic is Can AI revolutionize medical documentation and improve patient outcomes? And then the last topic for the day, this is a half-day virtual event by Reni Dua, Chief Strategy Officer. Hey, Reni. Her topic is Making Artificial Intelligence Work for Real Patients. So yeah, this is the agenda for the day. And I would just like to invite our first speaker for the day, Craig, to do the talk for the and start the proceedings for the great event which we have in store. May we have Craig and his team to take the start for the day. Craig, are you there? Am I audible? Arvind, am I audible?
I'm able to hear you.
Okay, great.
I
Thank
see
you.
you're really straight.
Okay. Craig, are you there?
Hey, can everybody hear me?
Yeah, I think there's issue coming at the Craig's end. Craig, are you there?
Yeah, give us just a second. Sorry, we're having technical issues here. Anybody know how I can pin Craig? Actually, that
So, Justin, there's a presentation which is there from Arvind's side. You can just start with that proceedings.
All right. And Craig is saying, hello, good to see everyone. I'm happy to be here today. My hope is that everybody can see me now at this point. Sorry, we had some technical challenges this morning. I'm thrilled today to talk about the future of healthcare for the deaf and hard of hearing community all over the United States. Uh, I'll go ahead and start with the first slide here, if you don't mind. Wonderful. So, today, many deaf people use American Sign Language to communicate. They use American Sign Language as their first language. There are roughly 2 million deaf and hard of hearing people across the United States who struggle with healthcare because they go to their doctor's visits, they go to their hospitals, and the tendency is deaf people run into language barriers. You can have a sign language interpreter, sure, but it's not the same as what hearing people experience because you have that third party interpreter who's relaying that information. And oftentimes that can cause misunderstandings. Oftentimes it can cause frustrations. And deaf people tend to, at a higher rate, have to go to the emergency room, and that causes frustration. I've even had that experience myself as a deaf person. I'm deaf. My wife is deaf. I actually have 2 deaf children. And my son recently had surgery at the hospital. And I remember being in the pre-op room, and I remember sitting with the doctor and preparing for the surgery. And the doctor asked me if my son had any allergies. And so I explained to the doctor the allergies, through the interpreter to the allergies that my son has. And I saw the doctor typing that in the computer, and the doctor printed a bracelet with that information. And just before I got this strong inclination, I was like, I should check to see if the information that they put on my son's bracelet was accurate. I grabbed his arm, I looked at the bracelet, and wow, it was the wrong allergy information. And that was a result of a misinterpretation or misunderstanding with the interpreter. And it scared me, and at that point I decided, look, I don't need an interpreter. I'll write back and forth with the doctor. Now, writing back and forth with the doctor, English is my first language. My first language is American Sign Language, so that's me having to function in my second language. I'd also now like to talk about just general challenges that we have in the healthcare environment, culturally, different barriers that deaf people all over the United States are experiencing. If we can advance to the next slide, please. So often what will happen is when a deaf person goes to visit a doctor's office or an ER, if there's an interpreter not available, the tendency is for deaf people to try and gesture, try to communicate where their pain is, what their illness is, whatever issues they're having with their health. And, they'll try their best to gesture. The doctor oftentimes, hopefully, will try to gesture back. And I don't know if you can imagine, even in today's world with the world of masks, it's even more difficult. With COVID going on and a lot of things switching to virtual, that makes it even more difficult. Using written communication, oftentimes I have to remind doctors and medical professionals, that writing back and forth, is not always that effective. You have to remember that, as I said before, English is not the first language of the deaf community. And I should say there are a lot of good interpreters out there, and interpreters are great, but interpreters are hit or miss. Finding a qualified, great interpreter, maybe one or two out of maybe 10. And interpreters also are not, medical professionals. They're not doctors, right? An interpreter is interpreting based on their understanding. Even if they are certified and licensed in that sort of thing, that's still, there are still barriers potentially there. Another option is the video relay service, but that presents its own challenges because it's very high demand. It's a very high demand for interpreters, and there's a very low supply of interpreters. So to meet that high demand, many of those video relay companies that are out there are now, using interpreters that are potentially, subpar or signed just good enough. And it's become an issue because for those who are not familiar with how the video relay service works is essentially a deaf person will connect via a laptop or a cell phone. They'll use software, a video technology software, and they'll connect and be able to see that interpreter on a screen. And that interpreter will make the phone call on behalf of the deaf person to the doctor, the nurse, or what have you. And the interpreter will interpret between the doctor, the healthcare provider, and the deaf person. This service has been available since 2002, 2003, roughly. So yeah, it's been around for about 20 years now. And the world, it's changing, and it's becoming more accessible. And I want to explain today how it should work, how AI technology and all of that is really improving the experience of the deaf and hard of hearing person all over America. Next slide here. You can imagine if a deaf person could communicate directly with their healthcare professional instead of relying on a third-party interpreter. That would be ideal. The company that I work for set up a COVID-19 hotline where a deaf person could call in and communicate directly with another deaf person and get information about vaccines, about COVID, about all of that. And for us, we saw a huge demand there. We were absolutely blown away with the number of deaf people who would call in to get that direct communication so they could understand in their first language instead of having to go to this third-party interpreter. About 10 years ago, we got a little bit of grant funding to set up a program called Project Endeavor. Now, Project Endeavor, we had the great fortune of being able to provide a direct accessibility support, customer support directly in ASL instead of having to use a third-party interpreter. And we worked with over 400,000 deaf and hard of hearing people all over the United States. The project lasted about a year, a little bit more. And it was, like I said, project-based. And we gathered a lot of data through this project. At the end of the project, we were able to send out a survey, and we asked these deaf people, do you prefer to communicate via interpreter, via email, via online chat, or do you prefer to communicate directly in your first language? And as you imagine, 97% said they preferred to communicate directly in American Sign Language with their first language. So with that information, we were like, we've set up and run a direct services call center. That's what we use to support the COVID-19 hotline. And now we're thinking about jumping into healthcare. There are deaf doctors out there who are fluent in American Sign Language and who are able to provide that direct care in American Sign Language to their patients. We did a little bit of research and we found that in the United States, there exists roughly 200 doctors who can do that, who can provide American Sign Language healthcare. And that's really the future. Communication in direct American Sign Language to deaf patients instead of going through an interpreter. If you could cycle the slide. Now, you can imagine a perfect world where deaf people would have that accessibility anywhere via their phone, where they're able to communicate directly with any type of handheld device they might have for their medical needs. The ability to text message as well. Oftentimes, deaf people tend to text to communicate in English in a different way. As maybe you know, American Sign Language has a different grammar and a different syntax. ASL fluent doctors who know deaf culture will be able to read into that English and maybe, understand when the words are reversed or in our grammar and in our syntax, which is helpful. There's so many deaf people also who are looking for employment. Deaf and hard of hearing people are 70% under or unemployed. So for us, looking at like care coordination services, where deaf people can have 360 support for their healthcare needs is something that we really we find that incredibly valuable. We can track, we can monitor, we can provide video, we can provide education tools, we can provide that 360 care for all their health needs. Also, we have the ability to use any device. So we're, webcam, video phone, their cell phone, anything to that effect. So we'll be able to have, a full care coordination team who has sign language and has a variety of specialties who can support this community. And our goal is to use the AI technology to increase these health goals, and provide that accessibility. And the reason why is truly because, at this point, the deaf community is behind in knowing what their healthcare needs are. They visit the emergency room at a much higher rate than their hearing peers because they don't know what's going on with their body, so they go to the emergency room. This technology, I think, has the ability to benefit them for that reason. All right. So yeah, if we advance the slide, please. So I'd like to say, at the bare minimum, we need to start looking into how we use AI and technology. We need to get these underserved communities at least on par with society as a whole, what society as a whole is doing, and improve access to healthcare for everyone. Not just, a subset of people or a specific group of people, but for all people. We need to make sure that those resources are available to support them. So I think for me, I'm done now. If we have any questions, thoughts, please contact me or please ask.
Thank you, Craig. Thank you for setting up the tone for the day. And AI in healthcare is obviously growing leap and bounds. And we are very happy to have you as a speaker, as the first speaker who set up the tone for this amazing learning and networking day. Thank you, Craig. There's a question, let me see, for you.
Sure.
What platforms are you considering? This question is by Kristen Dodd.
Right. So currently we're using Athena, and we're also going to use an internal ACD video solution that actually integrates. So that's the technology we're using right now. Yeah.
Thank you. Any other question, guys? If you have, just type in the Q&A section, and Craig will be happy to help you out. We'll just wait for 1 minute just to understand more on the same, if any question is there. Otherwise, we'll move on to our next presenter. So there is one question. Can this same technology idea be applied to other languages? For example, could this same model be used for Spanish speakers?
Absolutely. Absolutely. The platform can be designed for any language. As long as you have, I think the key is to have, a group of medical professionals who speak that language to be available on the platform. That would be kind of the key component that you'd need.
Yeah. How does accessibility create economic and community welfare? So this question is by Katie Murk. Should I repeat the question or
Sure.
it's okay?
Yeah, if you don't mind, repeat the question one more time for me.
How does accessibility create economic and community welfare?
Yeah, that's a great question. So a lot of data and a lot of research shows that health disparities in the deaf community are, astronomical almost. They're like 6 times more likely for a deaf person to go to the emergency room. And those 2 times more likely for a deaf person to go to the emergency room. And the deaf community, by and large, is 70% under and unemployed. So if we do drive them to, jump into the medical field, we're hoping to inspire people to join the medical field and become medical professionals as well with this. And that creates opportunities for them and accessibilities for patients. It's sort of a win-win situation. And we should also mention that cost of interpreting is skyrocketing at the time, right now. And these doctors' offices, these physicians are already spending that money for interpreters, and when they could be spending that money on healthcare. We find that there's so many benefits with regard to employment, with regard to patients, with regard visiting the ER, and all of that drives, economic welfare.
Great, great, Craig. I think questions are flowing for Craig, so he has to wait now.
Yeah, absolutely.
So who will pay for the service you are providing, the doctor or the patient?
Yeah. So our program will work exactly the same as all other services. It'd be paid through a subscription plan. So the patient has the option to pay. Also, depending on the insurance companies that those patients are using, the insurance companies will pay. We can bill insurance companies the same way, Medicare, Medicaid, in exactly the same way as their hearing peers do. It's truly the same support that anybody, with regular insurance gets at their doctor, just for the deaf community in their first language.
Yeah, great, great. Will you provide transcriptions of the visits being conducted in ASL?
It depends on what you mean by transcript.
Kristen, can you throw some light on your question? What do you mean by transcriptions? Will you provide transcriptions of the visits being conducted in ASL? That is what her question.
So we can, we want to make sure that the patient has access to all of the information. So, for aftercare, so it's an option to do that. Yes.
She has provided some clarification. Like generally, someone types out the conversation to refer to later when it is a spoken visit.
Yes. So exactly that. So we'll do record and track that stuff. We also have that for quality assurance to make sure that our patients are taken care of.
Great. One more question. What would you recommend current healthcare providers do when they work with deaf patients? How can they collaborate with this program to provide direct communication access in the best interest of their patients?
Yeah, great question. Yeah. So There are a lot of ways to do that. I think the number one thing is to see what resources are available in your community. Health signs, healthcare providers that know sign language obviously are ideal. Figuring out what your patient's needs are as far as communication goes, making sure that you have good quality sign language interpreters as a support also. If a doctor obviously doesn't know sign language, making sure that you find good medically certified sign language interpreters. That's a strong recommendation that I have. Yeah.
I think it answers all the questions. So there's another question. I know the questions are flowing. So can you share the company info and website so that we can follow up?
Yeah, absolutely. Yeah, I'd be happy to provide that information. Let me see here. We have a website that is going live actually in 2 weeks from now. So we can provide that information. I can send it to you, Nitin, and
Yes,
maybe you can forward it to the audience.
absolutely, absolutely. So once we get all the information from Craig and his team, we'll provide to all the participants on the mail.
That's brilliant. Yeah, that sounds good.
Also, we will share the presentation which Craig was presenting to all the audience, so that it's easy for you to grasp when you go back. Thank you, Adriana. So there's one link which Wayman has shared, that is healthscience.org. So you can get the more information about the program which Craig and his team is working on. Yeah.
Yeah, absolutely. That's
Thank you, Wayman. Thank you for the link, and we'll stay connected. Thank you, Craig. Thank you, Dustin. Thank you, Wayman. Thank you for all the support and great presentation. Have a lovely day ahead. Thank you.
Thank you so much.
Thank you. So, guys, we'll quickly move on to our next presenter, which is Len Bickman. Len, have you on stage? You can turn on your video so that we can see you. Oh, great, Len. Thank you. Maybe have his presentation also up. So before Len starts with his presentation and we can set up the tone for him, just a small introduction about Len. So Len is Chief Artificial Intelligence Officer at OnRack and OnTrack, and his topic is using augmented intelligence, how he is transforming at his company. So maybe have his presentation set up. Yeah. So Len, we can see your presentation now. You can pin your presentation.
Okay.
And start with your presentation. Thank you, Len. Over to you.
Well, thank you for this opportunity. Good day, good morning, good evening, like you said, to everyone. Let me tell you a minute about what OnTrack is. It's a company that specializes in working with primarily health plans that address behavioral conditions and chronic disease among their members, and attempts to improve their health care as well as reducing medical expenses. Next slide. Just a little bit about me. I am new to OnTrack. I started in November. As you can see, I come from an academic background, and my experience has been primarily in the area of mental health services research and program evaluation. Next slide, please. All right, so what is OnTrack and what is our model? We're using AI to engage the members who have both complex comorbidities, physical health problems, and mental health problems, who have unaddressed behavioral health conditions, and that represent a disproportionate cost to health plans. Our aim is to decrease unnecessary utilization by providing highly specialized care coaching and connecting members with mental health providers to drive durable outcomes. So what are the four main parts that I see as in our model is we use AI to target individuals who are eligible to participate in our services from the health plans. This includes those who already have diagnoses of behavioral health conditions, as well as using AI to impute those who have yet to be diagnosed. We try to identify members who are underserved, not receiving services that they need to receive, and we estimate their readiness to engage in services, because these are typically hard to treat, hard to engage individuals. Our general approach is to use what I've written as a precision behavioral health approach, where we try to pair members with with two sources of treatment, basically, our care coaches and mental health providers, so that we produce optimal outcomes, and where we use this information to direct the member along certain clinical pathways. The system is powered by a measurement feedback system. This system collects information from the member and actually the coach or provider on a session-by-session basis and feeds back interpretations in real time. One of the problems of most mental health services is that it does not provide information to the people providing those services that they can act on to improve them. That is, they often do not learn from what they're actually doing. This has produced successful impact for us in terms of reduction of AR visits and inpatient stays. Next slide, please. All right, I'm going to go through a series of slides where these essentially trying to describe how we're infusing artificial intelligence every step in the member's journey. So we're starting with the members at the start of the care journey. And there we use it mainly for selecting members to participate. And what I'm going to describe in the next few minutes is how we infuse it into every step of the care journey. Next slide, please. So previously we used pre-post measurement, which as a researcher in the area is just not very adequate for judging success or providing any information to our people providing treatment on how to improve their services. Now we use a continuous measurement feedback system that collects and scores information throughout the member's journey, collecting data at every session that the member participates in. Next slide, please. Where before our indicators of engagement or progress were lagged. We got the information after they did the service. Now we're using information in real time to try to predict whether or not the member is having sufficient progress and to prevent dropouts, which is a critical aspect of most mental health services where the dropout rate is typically very high. Next slide, please. Care activities are typically described in most systems as commodities. They're hours, number of sessions, and it doesn't tell you very much about what goes on in those sessions. Without that detailed information, that more granular information, you don't have a clear view of what services are actually being received. So in our system, every session gets recorded and automatically summarized. Next slide, please. Supervision is part and parcel of all the clinical trials that take place. However, in the real world, outside of clinical trials, there's very little effective supervision of what takes place in sessions. Our system has an automated supervision through natural language processing algorithms and our continuous measurement feedback system. So it's a much manual approach, looking at session by session progress, looking at both the processes during treatment or services, as well as the actual content of what is being discussed in a session. I'd like to say that other than priests, therapists have absolute privacy to what goes on in their session. This opens it up to looking at what are they discussing? What are the issues? If it's an evidence-based treatment, are they following what they should be following? Next slide, please. One of the innovations is if you use evidence-based models, you're pretty much relying on them as static existing models. The best you usually can do is follow the steps in a model, but you can't change it very much because you're not collecting any evidence of the effectiveness of various components of models. One of the things that we can do is if we're finding various components are not working for most of our providers, we can provide feedback to actual model developers saying, here's an aspect of your evidence-based treatment that's not working very well. We think you need to reconsider how you're actually telling us how to implement it because it doesn't appear to be working as you expected. Most model developers, I'd say all model developers, nobody gets that type of information. And so we're really stuck with static models that don't change based on improvement over time. In the long term, this not only improves what our members are getting, but also improves the relationship with model developers to be able to improve their models. Next slide, please. We have heavy claims data, lots and lots of claims, thousands and hundreds of thousands of cases, but claims data are very limited in what they provide to us. Now in this new system, we have engagement activities, we have standardized measures that we provide for each session, and as I pointed out before, the natural language processing scores, both on sentiment analysis, as things like empathy and turn taking, as well as content of what's being discussed. Next slide, please. So we've had basically claims data, you have engagement data, you have various sources of data that's difficult to compare within the same system. Now we have a single AI-supported MFS that includes all data collected about the member, our coach who provides specialized services, and the mental health provider. Next slide, please. So what I'm trying to communicate here is OnTrack is transforming every behavioral healthcare journey, and that's what we call it, throughout our care coach-led and AI-infused measurement feedback system, produce a precision behavioral healthcare system. Now I'm going to take you in more detail to what this journey looks like. Next slide. So I've just picked out 9 points during this process, and if you sort of look at it, it starts with the very aspect choosing or recruiting members to participate, taking them through the process where we engage with them to participate with us, because they don't come to us, we need to recruit them. What we do during our sessions with both coaches and providers, what the actions are, and what the durable outcomes that we produce. And so we call this our approach is AI-infused service delivered, a precision behavioral health kind of approach. And what I'll show you is very briefly, each of these black dots will turn red with a little description of what we're doing at each point. Next slide, please. So on the first thing, we're using AI to predict future engagement and potential return on investment of prospective members based on claims data. This helps our outreach agents prioritize who they try to recruit to participate. We want to recruit the members who are both underserved. More details on what this journey looks like. Next slide. So this process, and if you sort of look at it, it starts with, I'm getting an echo. Aspects. In the second point, AI matches members with the best agent and coach for member engagement, outcomes, and dropout potential. Next slide, please. In the third step, we actually engage in reaching members, and this is primarily through telephone. And there's various scripts that our agents can follow, and we're using AI there to customize what script that should be work best to maximize our engagement. Next slide, please. In the fourth step, both our agents who recruit members and our coaches who provide up to a year of services with them are using motivational interviewing, which is an evidence-based treatment. And this is being recorded and scored both for sentiment, as I pointed out, sentiment being things like the degree of empathy, as well as evidence that they're following the steps that are required in an evidence-based treatment. This information can be provided instantaneously to the coach during their discussion in their dashboard. Next slide, please. Coach notes, any note system has been a real problem for most services. They take endless amounts of time and they're often underused. We're using AI to take the call notes and essentially liberate coaches from data entry tasks by providing theme-based summaries of these notes to them that they then can review. Next slide, please. We collect session-by-session data and use this information to signal about poor progress and potential dropout so that our care coaches and providers have this information at hand to try to deal with problems that can be anticipated based on the data we already have collected and using AI to predict which cases would have problems. Next slide. One of the issues with any mental health service is providing the right service to the right person at the right time with the right provider with the right problem. It's been a problem for mental health services in almost every service forever. AI is now being used to try to deal with that problem by matching characteristics to produce an algorithm that would predict which type of coach or provider with what type of problem, with what type of treatment works best with which types of members. That's what we mean by provider matching. Next slide, please. The engine that we're using communicates opportunities for improvement in real time. As I said, some of the things that can improve are based on their own sentiment analysis. How do they improve empathy issues? How do they improve turn taking? Some of it is fidelity to the evidence-based model. This information can be fed back to both the individual and the supervisor, and they can be directed to an online learning module for them to actually learn to do it better, and then we can actually check on subsequent data whether or not they've been improved. Finally, in the next slide, we're looking at durable outcomes, both financial and mental health and well-being. We track individuals throughout that process with us, as well as 12 and 18 months later. We're going to use this information to inform our algorithms, our training, and to continuously improve our effectiveness. Next slide, please. Okay. I've got a few minutes for questions.
Thank you, Len. We just wait for a couple of minutes if an audience has any question to you.
Okay.
So guys, if anybody of you have any question, you can type in the Q&A section, which is there on the right side of the menu option. You can type in as the speaker speaks, so that easy for them to answer it after the end of the presentation, and we can save some time on that. Yeah. So if anybody of you have any question for Len, you can type in the Q&A section. We'll wait for maximum couple of minutes, and then we'll start with our next session, which is a panel discussion. Just to let all of you know that we'll be sharing the speaker's presentation to you on your email so that you can see at the later stage when you go back. In case you have any thing, you can connect directly with the speakers as well. Yeah. Thank you, Len. Thank you for the lovely presentation. I think we'll start with our next presentation. Thank you, Len. So may we have all the panel members on stage with the video on. So I'll invite all the panel members so that easy for you to understand. We have Chitrai, who is CTIO InfoVision, is the moderator. We have Sai, who's co-founder and CEO, IASO. We have Mithul Shah, who's VP AI Products, Prosia. We have Rich, who's Health Industry Executive Advisor, SaaS. We have Natasha, who's CEO and founder of InnoBot Health. We have Jayadita, who's Senior Director of Data Science, Included Health. Oh, we have all now taking stage. So one Jayadita is missing. She will just join back. In the meanwhile, we can start with the panel discussion. We have good amount of time for the panel discussion so that all the questions can be answered. The panel discussion is till 11. So we have 1 hour, 20 minutes with you all to set up the stage and meet a fiery stage. Over to you, Chitrai.
Thank you. I think we are waiting for one more. And good morning, everyone.
Natasha will join. Jayadita will join.
There. Good morning, everyone, and thank you so much for taking time. And really wonderful presentation from the people who presented before. 2 more people. Really very insightful, and really I'm impressed with that information what they are sharing. Hopefully, our conversation will be more interesting as well, because we have a lot of questions and expecting more answers from you as experts. Let's have a quick introduction before we move on. We have some more time. Let me quickly introduce myself. This is Chitrai Mani, and I'm the Chief Technology and Innovation Officer from InfoVision, heading the innovation unit of Digit7. Digit7 is a subsidiary company of InfoVision, and I'm the CEO of Digit7 too. And apart from that, I have been handling multiple companies as active CTO. We are very focused on innovation, especially in multiple domains, healthcare, retail, as well as telecom. We have been focusing. Over to the people as well. Please start from Mithul Shah. Please, can you have a quick introduction?
Yes, thank you for the introduction. My name is Mithul Shah. I am the Vice President for AI Products at Prosia. At Prosia, we are a company that develops software for the digital pathology sector. And we develop the platform to be able to read and diagnose digital pathology images, as well as use and be able to develop and use AI technology that supports the lab and pathologists. I'm pleased to be here and looking forward to this session.
Thank you, Mithul. Rich?
Yeah, good morning, everyone, or whatever time it is, wherever you are. Thank you for the opportunity to join you all. My name is Rich Kinney. I'm a nurse by background and now act as a informaticist and a healthcare industry advisor to SaaS. I imagine everybody on here knows, or at least should know, of SaaS. We've been doing AI before it was cool, back when it was called just statistics, for the last 40 years. And so in a lot of ways, the founder and the future of analytics, we're doing a lot of very interesting things. Most of our innovation and where we lead in this space has been in other industries. I think, frankly, just because the technology in healthcare and some of the challenges have impeded growth in healthcare. So I'm really excited to be joining the rest of you all today and to be able to talk about how we're seeing AI starting to really advance and mature in the healthcare space.
Thank you, Rich. Hi, Natasha. Quick intro. You're on mute, Natasha.
Oh, sorry, I didn't realize you were talking to me. Good morning, everybody. I'm so excited to be here and talk with you all today. I'm Natasha Schlenker, CEO and founder of Innobot Health. We do robotic process automation and specialize in revenue cycle management, particularly. I've got over 25 years of just trying to identify and fix barriers to physicians and healthcare systems being reimbursed. And so we're really excited to share what we're doing in robotic process automation.
Thank you, Natasha. Ty Wachan.
Hello, my name is Ty. I'm a radiologist by training, and that's why I have a giant computer behind me there. For the last several years, I've been working on ways to get AI in healthcare working, and it's really cool to see on this conference. We've seen for American Sign Language, we've seen for mental health, we're seeing for automation for lots of things here. So this is an exciting time to be a part of it, and I'm part of a company that's looking to apply it to telemedicine as well, and we'll talk about that a bit more. Good to see everyone.
Absolutely. Thanks, Ty. I think, Jayodita, you are not on video. Could you please enable your video as well? And you are on mute too.
I think she joined and maybe, she's here now. Yeah.
She there? I don't see her.
I can see her. Maybe she's having some technical issues. She will join back.
That's fine. Let me start with.
Yeah.
Good morning, and let's start the discussion quickly. Let's go for it. I know healthcare industry is very critical, especially after COVID. I'm not using the word after COVID, still it's COVID. It's a new version is keep coming up. I'm waiting for the word, hey, after COVID, everything changed. I'm waiting for the timeline when it is going to be. Every 3 months, it just keep coming. People are a little bit tired of. And definitely healthcare industry is one of the saver, how to save the people. Really a lot of healthcare people, even nurses, healthcare providers, doctors. Really, I want to take a time to thank all of them at this moment. Your services were really incredible for the last 2 years. Because I have gone through recently, I got COVID Omicron. I came out of it, but I know really how it happened, how it is worked. Thank you so much for all of your services. And let's start from the question. It's both the question, pros and cons questions will be there in this channel, in this panel. Okay, the first question, let me start with. Who will benefit from AI in healthcare industry? So I know some smiles from the faces. Let's start with Rich. It's a very hypothetical question. I know that because it's maybe a patients or the providers or who's really getting benefit out of it, enabling AI.
Yeah, I laugh because the immediate answer is like everyone, right? For many years, at least in the healthcare space, we often talk, or we heard from the Institute of Medicine around the triple aim, right? When that first released. At least in the healthcare provider world, we quickly expanded that to the quadruple aim. And I think it's a very important distinction. And so maybe I'll start there a bit and some others can add on some commentary from there. But if we look at that, for those who might be unfamiliar with that, we talk about the need for healthcare to reduce cost, to improve quality, and to enhance the patient experience. That fourth aim is about also remembering that the clinician or the provider's experience is also important in this. What we've done historically over the last 10 years with all this EMR effort has been largely at the expense of the clinicians as we've subjected them into becoming nothing more than data entry specialists. And I think that's what's most encouraging and most promising from my point of view as far as who stands to gain from the advances in AI are the clinicians and actually improving their workflow, getting them back to practicing what we call top of license. And Ty, I'd love for you to kind of chime in and hear a little bit from your experience and what you're doing as a radiologist with telehealth, but then those other pieces as well. So if we talk about patient experience, and I think to your point, with regard to the pandemic, we I think we've shifted that, rightly so, into a conversation about access and equity. And so patients have a lot to gain as well in the ways that we apply AI, in many of the ways that Lynn kind of speaks to and teed us up for this conversation. So the short answer is everybody.
What about Natasha?
Yeah, I would have to agree with Rich. Definitely. The patient obviously is the top priority. They're the reason we're all doing what we do every day. And the providers, and then all of the office managers, the C-level executives, and the end users that are, they're overworked, especially in the staffing shortages. We talk about the pandemic and the impact that it's had on the healthcare world. People are overworked. They're working long hours. They're working on the weekends. Their families are not getting to spend time with them because we just have to get the things done that we have to get done so we can continue to treat patients and evolve the healthcare across the globe. And so I would say even those that are not involved directly in healthcare, the families, the children, the husbands and wives that are waiting for their families to come home. So literally everybody.
True. Mithul, before Mithul start, still I have a point. The investment on all this AI is still, we are incurring from the patient only. That's what that's what I'm trying to get the point of. The real advantage, who is taking care of it? It's really a patient or a company who is investing on the AI. These are the kind of hypothetical questions going on. Please go ahead, Mithul. Just I want to put the point here.
Yeah, no, it's a good point. And I would say ultimately we're all here to be able to provide the patient with the best experience and best quality healthcare, period. In order to do that, you need individuals, nurses, lab technicians, pathologists, other physicians who are critical in the life cycle to be able to provide that quality care to the patient. So if AI, another tool, can help them, then we're accomplishing our objective. So what needs to be done is we need to be able to prove at scale that AI actually does make a difference, that can help, as Rich and Natasha mentioned, it can help the physician or the first line of providing quality care to the patient, to be able to do that at scale. And then I believe at the end of the day, the patient will benefit. But it takes the individuals who are actually practicing to be able to actually validate that concept.
Absolutely, absolutely. Ty, in your point of view, what do you think about this question?
One of the things that we all know on this panel that hopefully we can continue to educate the rest of the patients is AI does great at solving one problem, and we've got like 20 million problems in healthcare. So it's going to take a lot of people like us on the call and people listening on the call to focus on one specific thing, maximize results, and get great results for the patient. And remembering we're all patients too. So as we're kind of going through our journey as patients, hopefully we can use those lessons and have good feedback loops. So I just would like to just say to anyone who's kind of listening, there's lots of problems to solve. So buckle up and let's work on this together.
Sure. I think Jayodit is also back, but she might have missed the question. That's fine. But I want to give some statistical information about the reason for the question. It takes normally 12 years, any kind of drug research taking from lab to patient. Right? That is the industry trend currently. And apart from that, if you are more than 5,000, if you take about 5,000 research are going on, only 5 medicines are reaching the preclinical to human trial. Okay, think about the timing, investment companies are investing. It is close to each drug, at least around 349 million, 350 million needed to bring into the human reach. That's why the investment is heavy on that side. So hopefully AI will help to reduce this timeline, cost, everything. That's what the industry speech is going on currently. That's really evident as well recent time of COVID time, and which the vaccines came up very quickly within 1 year. Okay, the next question I would like to move on. What will be the impact be on doctors and other healthcare workers using AI?
Yeah, I think when we talk about the impact, as I was kind of mentioning before, looking at all of the people that are working so hard all the time, trying to get through all of the massive volumes, particularly through this pandemic, the impact is really taking a toll. It's taking a toll on the administrative staff, the front office staff, the nurses, et cetera. And I think when we look at the cost of healthcare as a whole, AI is really impacting the cost of healthcare to a point where we're going to see a lot more access to healthcare in rural areas because the cost to deliver healthcare as a whole will be reduced over time.
Absolutely, absolutely. All right, quickly take on.
I will. Sorry, I was going to chime in on this one too. Sorry for joining a bit late. I'm Jayodita, and I work at Included Health, where we try to help members route through this complicated healthcare system. To add to what Natasha just said, I think AI definitely helps drive down the cost of healthcare, making more accessible to populations at large. AI also enables us to deliver more aspects of virtual care, which, to your point, Natasha, is going to help enable care to more rural areas as well. I think beyond that also, it helps make the system more efficient. So if you can get people to the right care for them faster than them having to maybe go through a number of different providers to get there, basically optimizing their route to get to the right answers and the right treatments, and you remove that waste, you can actually make each of the providers in the system more efficient in themselves. You can help them kind of take on the cases that they actually are interested in and kind of trained to go address versus a lot of what they currently do, which is kind of also figuring out some of the inefficiencies in the system, paperwork, etc. So we can take the supply that we do have and make all of them more powerful.
True, absolutely.
Yeah, I would add to that. I think what you said, Joe, is correct. The ability to triage, to be able to take a large sum of data that exists that is prone to human error, and have AI employed to be able to triage and be able to classify and be able to auto route to the right individuals so that specialists are seeing more in-depth, more specific cases that are more probably associated with them, and be able to route other tasks or other responsibilities to other individuals where it makes it more important. That's just the first layer of what AI can do. Beyond that, then there's an option to diagnose and to be able to predict. And those are the three levers that we kind of run as in terms of our philosophy of how AI can actually impact the pathology sector at Proscia.
True, absolutely. So quick question on, I know I wanted to make sure the statement, you mentioned that AI is improving, but what will happen if AI detection went wrong? What is the impact? Have you guys, anyone faced it in your real time or anywhere in these use cases?
This has been pretty prevalent in the radiology space because radiology was in the media for the last couple of years, and the vendors, and now I'm on both sides, I'm a radiologist and I'm a vendor. The vendors always say, "Oh, it's up to you and your medical license. Good luck." And so that always kind of rubbed me the wrong way. And so ultimately, yeah, my name's at the bottom of the report, so it's my responsibility. And so I think that's why when I was saying we need to focus really specific on specific things. So if there's an AI algorithm for multiple sclerosis or lung cancer, I need to use it as the provider to get super comfortable so I know when it's outside of its guardrails and I need to put my doctor hat back on and rein it back in. So ultimately it's going to be up to the provider because we don't have another system yet. But hopefully vendors understand that, we're people too, and we want to do a good job for the patients, and we can collaborate with vendors and providers to make sure that it's as safe as possible for the most amount of people.
Absolutely. Yeah, sure. And one quick question. With a significant increase
chime in and add to that.
Recently, go ahead, Rich.
Oh, just to kind of tack on to what Ty is saying, and even tie it back to Lynn's presentation earlier about There was a subtle description when he was calling AI augmented intelligence, and I think it's important for us to use that language. The intent is not to replace a provider or a decision maker; it's to augment them. In a lot of the ways in which we've deployed AI in healthcare, it's doing that. It's surfacing these suggestions or these recommendations, these scores, these risks, or what have you. But it's all to augment the providers in their decision making, and we don't want to lose sight of that. To that end, that also means that we, as the technologists, have to make sure that there's explainability in what we're doing. This notion of black box AI, that's where the problems are. And so that's one thing, is making sure that what we're developing when we're applying these advanced analytic techniques, that we are creating it in a way that is explainable and easy to understand for a non-technologist, so that they know how to then interpret those results.
True, absolutely. And as I start the question, with the significant increase in telemedicine visit recent days, most of them are virtual, right? What are some useful ways to evaluate the new digital audio and video data? Ty, you would like to take it?
So this is a good extension from what Len was talking about. One of his really specific things was like teasing out some of the sentiment data, how connected is the provider and the patient. And this kind of ties in a lot of things we're talking about. If there's an EHR over here that I need to fiddle with, patients like, hey, I'm over here. This is where my eyes are. And so particularly in the last 2 years, we've had to go from like human beings where we like get and talk and meet people and touch, and now we spend a lot of time on the computer. And so there's a lot of opportunity to collect video data, audio data, to try and capture how empathetic is the provider, how much does the patient understand what the provider's saying. So it's and we all know providers that don't do a great job of this in person, and then it makes it even trickier putting a screen and a camera and da-da-da. So I think that there's a lot of opportunity, a lot of data points that we can collect to help guide some of the providers that don't quite know how to zoom their way through the days as smoothly as others.
But don't you think the in-person physical examination is way better than your virtual examination? Even we and all, as you mentioned, all of us are really patient, no question, one way or other way. But we feel more better when the doctor sees us in the physical. Any problem is way important, better than the virtual side. So
this is a great question. So we're tending to put that in the box of something you need a physical exam. A mental health encounter, there doesn't need to be a physical touch. And so this gets a great point to even what Matul was saying, touch points in medicine. If you sprain your ankle, you need to see someone who's going to exam. But if you're feeling anxious and depressed, you could probably do this online. And so putting the right patient with the right person at the right time is something we do a terrible job at, just absolutely terrible. And that's one thing that we can use to help. So if telemedicine can help get the person to the right place at the right time, then that's a huge step in the right direction right there.
To add to what Ty is saying, I think virtual care also really fundamentally helps address the access problem. So Ty gave the behavioral health example where we have a shortage of behavioral health specialists in the United States today, especially in pockets of the country. There's also a convenience factor. People work basically the exact same hours where providers are available. So it's really hard for them to schedule appointments and get in, especially in a timely fashion. So much of the country does not have a regular primary care physician today. And a big part of that is because it is hard for them to get into care. And so virtual care does open a lot of new doors for care that was not available just with in-person care. And if we can figure out the right model of using the two together, it can be really.
Yeah, that's really important, Jayadita. And I think when we talk about that, and we're also talking about how we support providers, and we talk about value-based care, and that's been such a huge talk, and particularly in some states like in California, there's a lot more of that value-based care, P4P, HEDIS, where you have to meet a specific measure and treat so many patients, but it's difficult getting a hold of the patients, getting them into the office. And so I think this really helps to increase that preventative medicine, which truly does help reduce the hospital visits, ER visits, et cetera, because we're capturing things earlier. And then back to, Ty's point on mental health, I think a lot of patients that have some of those mental health conditions don't really like to be around people. They don't want to get out and, have to go. It creates more anxiety for them trying to get to the doctor's office and be there. And they're worried about, COVID and other illnesses. And so when we open up that telemedicine, it's just another avenue. And it doesn't necessarily, and to Mitul's point, it doesn't necessarily take away from that we still have doctor's offices that are open and there are those face-to-face visits, but it's just another avenue in parallel.
But what are the challenges? I know we are talking about all advantage about the telemedicine. What are some challenges to leveraging telemedicine audio and video data? So any point?
Yeah.
So, okay.
Go ahead. I'm sorry.
Go ahead.
So I implemented the telemedicine platform for a very large wound care physician that was in 27 states and over 300 providers. And so when the pandemic first hit, it was really challenging because when you think about wound care, a lot of those patients are Medicare, they're elderly patients, and their technology understanding can be quite challenging. And so trying to find, a next of kin or somebody that can help them get through that. And then you have to be able to see the wound. And then sometimes there's debridements or those kinds of things that you have to navigate with, either a home health provider or something like that. So I think technology can be challenging, but the further we get into the future and the more we help patients embrace it, I think that we'll see that start to be more accepted.
Sorry, Ty, any points from your side?
Again, stemming from what Len was talking about, so they have a really specific niche where they're working with behavioral health, mental health on their kind of patient journey. If we wanted to evaluate everyone's audio and video, there's some privacy concerns, there's some security concerns. There are things that we need to obviously address before we can make that scalable to everybody. And ideally, the things that Len's talking about is available to everyone, not just people on that exact mental health kind of treatment pathway. So that there's security and compliance stuff that we've had to learn over the last couple of years that weren't really around before, at least not at the same scale. And quite frankly, like in the hospital, like in the clinical setting, like there are some pretty old things that we need to rethink to hopefully modernize in-person and telemedicine care too.
True.
Yeah,
and the language, yes, is one of the big important problem. Recently, I faced it too. Yes, please go ahead, Natasha. Thanks, Natasha.
Yeah. Sorry. And one of the things is, like patient forms, consent forms, et cetera. So a lot of the hospitals and in-person visits, to Ty's point, is still on paper. And then those are scanned in. It's crazy. You would think that it's not, but when you go in and you're doing some audits and analysis at various different healthcare systems, it really is. And so trying to transition from some of those older ways.
Sure. Rich, any point about this challenges of telemedicine data, video and audio?
Yeah, I mean, I look at video and audio as another data type, just like we've talked about free text. The biggest thing is all this new influx of data with all these devices we all now have on our wrist, and the challenges with ingesting all that. And so, SAS, we're talking about this in regards to edge analytics or event stream processing. How do we process that so we're not throwing all that into an EMR and expecting a clinician to figure out what to do with it all? So there's a critical use case for AI there. And I think that kind of touches on Arun's question in the chat as well around what's happening on the regulatory landscape with regards to AI and medical devices, right? We're seeing some of this around software as a medical device, and FDA is starting to regulate that. And so a lot of that is what we have to be mindful of. And what I think goes back to my comment earlier, I think what's critical is for us as technologists is to make sure that what we're developing is easy to understand and is explainable. And let's get away from this black box AI, because that's where all these companies end up with a black eye. When someone reverse engineers an algorithm, large EMR companies notwithstanding, and recognize that it doesn't perform as expected. So I'd probably just kind of add that piece in there as far as a comment.
Sure. And I think maybe adding to that, and maybe also addressing one of the questions around NLP. So to the point that's being made that the EHR system is pretty fragmented, not interoperable, and a lot is in unstructured text. Again, what we get from a lot of the virtual interaction is the audio of the interaction between the provider and the patient. And if you transcribe that, where transcription technology has also gotten really good in the last few years, it gives you a text version of the interaction, where, of course, video is the next step, but text is the place to start. And you can do the NLP analysis on top of it to try to understand what's in the interaction and maybe make a more structured, informed form than the clinical record itself. The challenges with that is, of course, the data security. So, for example, the first step would always be redacting any personal identifying information from any of those transcripts before you could use it for any form of analysis, and making sure that that process is as precise as possible, and so that you have a clean set of data to work with. There's also all the taxonomy work, right? It is a whole dictionary of language that is very unique to this field that you have to train this nature of models on to make sure that you're learning the right things from this. And so there are a lot of challenges that go into this space, maybe as that might be a little bit unique within health tech as compared to other spaces that maybe require like an even higher degree of carefulness and, an eye for precision on things. The last layer is making sure that the learnings are really, really well validated. Kind of our take is, for a long time into this, you really need to make sure you have a human in the loop, the clinician in the loop, to make sure that the judgment and logic coming out of anything that we're learning from this data makes sense to the medical professionals.
And to take that one step further to the decision support part. Oh, sorry.
No, I definitely want to request to most of the healthcare providers in this call, please move from the paper filling to digital as soon as we are in 2022. We are tired of with that. Okay, wherever we go, we are filling up multiple papers. I don't know. I know HIPAA compliance solve the problem. I understand, but still, it's 2022. We are digital. Still, it is not moving. The one industry which is moving very slowly in the digital area is healthcare. I don't know whether you agree with it or not. Telecommunication, video, audio, all the service is good, but still the data privacy, all the stuff, still we are not there. And that is what we are spending first 20-25 minutes in the hospital or anywhere clinical, filling up the form. Just to inform you. Muthu, sorry, Ty, please go ahead, Ty. Sorry, I interrupted some points.
Well, I was just going to take the second part of that, the CDS, the decision support from the NLP. And so this is something that we saw in radiology starting 10, 20 years ago, where it's like, if someone has back pain, they don't need an MRI 5 minutes later. Like that's not the best use of the resource. And so if we're able to accurately pull in NLP and get a good history, my back's been hurting for this long, I've had a fever, I had a car accident, I have cancer. Yes, get in for the MRI. But, I'm just kind of lazy, I don't work out, my back kind of hurts. No, don't get an MRI. So that's where the accurate NLP helps with the CDS part. And, neither of them are going to be the end all be all, but if each get great, then we can at least start to have some metrics that are more actionable for how providers use resources. And we all need to be good stewards of resources in pathology and radiology and labs, and just people's time. And so it would be awesome that if we can get NLP so dialed in that we can start to use the decision support tools the way that they're kind of supposed to be. Because right now, honestly, it's pretty tricky to get the full impact out of them.
No, absolutely. I have one question relevant to that. So when you talk about the data, NLP, a lot of things, even with your products, right? The data is shared to a lot of other companies too. This is my personal data, keep in mind. Okay, it's shared to a lot of things. From there, you are creating your analytics, all the stuff, and intelligence, right? So how secure it is? So is it good to share with, because think about Facebook or Google or Amazon, everyone is having your data. That is true. Your healthcare data or whatever. I'm not talking about the pure HIPAA data. Still, whatever information you are filling, searching, everything, they are relevant. They are suggesting you, hey, this is the best product, all the stuff, right? But you are also using, correct me if I'm wrong, everyone in this company, even Natasha or Mithul, Jaya, all of you using the data from the customers and on top of it applying the NLP or the intelligence. So how safe it is? Is it good to share with other companies this data or no?
Well, I can tackle that. It's a tough question because it's multifaceted and multi-dynamic just in terms of an answer. But I think one thing our government, at least the U.S. government, and I'm sure many other governments have done well, is be able to really enforce HIPAA and really enforce PHI and the good work that others have done just in terms of NLP and to be able to scrub and be able to develop anonymizers in terms of data and data acquisition. I think the regulation, the restrictions are all very appropriate. I think along with that measure, if we can continue to enhance those regulations, those restrictions, at least I know from our, how we train our algorithms at Proscia, we make a very concerted effort to address bias. We don't want to know one person versus another person, what demographic, what their name or sex or whatever it might be. We literally look at each record that comes through as an individual that has zero bias, and we try not to add that bias to any of our kind of diagnosis or any of our AI applications. And so, we have individuals on our team that make sure that PHI, that we are following and, we are ISO HIPAA compliant. And that allows us to be able to make a product that is scalable because it addresses each individual as an individual as opposed to treating certain demographics with a certain bias.
Got it.
I think the notion of data, of who owns the data, is critical. Any company who's dealing with data or is in this space, having someone with a background in ethics is probably a really, really good idea, because we're still uncovering challenges and misses, frankly, right? Where we didn't catch the bias that was in the data just by some of the ways that we're looking at things. And so that ethical use going forward is critical. And then, everyone wants to own the data. And naturally, we've got a bit of a conflict with that at times. I think the best path forward is really building a system where individuals are the owners of their own data. But what does that mean for a health system? Because are they the ones that are technically generating the data? Well, then you've got payers at play. You've got EMRs, right? I mean, you've got this whole potential Oracle acquisition, that's going to pull through. What does that mean for Oracle to have all that data? I don't know. Am I comfortable with that? Maybe I'll give another example for the companies on the call. Let's dissect Microsoft, who acquired Nuance a while back. That became attractive because Nuance acquired a startup called iScribes. Well, iScribes was working for years on basically what they were doing is recording the physician's visit, and then they were manually transcribing that with scribes back into the EMR. So they've been collecting all this data manually. They have all these recordings. Nuance acquired that, to start training that into more AI. And then, of course, that became very attractive for Microsoft, who now has all those recordings and is developing their clinical, I can't remember what they call it off the top of my head, their clinical artificial intelligence tool where it listens. It's a device that listens and automatically transcribes what's happening in the room into the electronic medical record. So there's a lot of great uses, but I think everyone are rightly bringing up the concerns with that of, we still need to be very mindful of what the implications for that could be. There are great uses, right, where we look at the research around it was done out of Chicago around zip codeomics, for instance, and identifying there can be up to a 20-year discrepancy in life expectancy just based off your zip code alone. Well, that then becomes a very important data point that we should probably be ingesting to understand the health of a population. Okay, but now for identifying down to a zip code where people live, like that now surfaces privacy implications. So it's a very difficult balance. And again, the point I want to leave everyone with is just it's critical to make sure that what you're developing is transparent and easily explainable.
Sure. Continue this area of question. I would like to hit a direct question to some of the people directly on their relevant area. To Natasha, how automation is going to impact the healthcare staffing shortage, short term and long term? Because you're relevant to this RPA, a lot of things you have been doing. Why can't you go ahead?
Yeah, I think that that's a really important question. We look at, you see the Becker's reports that are coming out all the time, right? That this hospital is closed, this hospital is closed. We see so many acquisitions. And as we're closing hospitals, when we're looking at the triple aim and all these other things that are supposed to be improving access to healthcare for patients, if we cannot maintain being able to get these healthcare systems and providers paid for the services that they're providing to patients, because of, look at average days in AR sitting out there. We're going past timely filing to insurance carriers, and it ends up being bad debt, uncollectible, uncompensated care. And when that happens, then the physician simply doesn't have enough, or the hospital simply doesn't have enough revenue to keep the doors open, and that impacts patients directly. And so as we start looking at how we're developing robotic process automation to automate some of the tasks like verifying eligibility that would usually take 10 or 15 employees, and we can get it all done overnight and have a report and have it placed back into the patient's EMR, obtaining authorizations in advance, sending out, looking at the medical coding and doing some automated audits on that, and sending it where it's only the exceptions that are being handled by people. And kind of to, Ty and Rich's points is that it's supplementing the staff. It's not replacing them. There's always going to be a need for somebody to look over it. There has to be audit, compliance, quality. But if we can supplement that and do some of those menial, mundane tasks, just to help improve the way that we deliver care as a whole, I think that's how we're going to be able to get through this staffing shortage. And it's a phenomenon that so many have been trying to explain. Where are all the people going? Well, we don't know, but we know that bots don't get sick. They don't post about their peers on Facebook. They don't call in. And, so I think it's something that's scalable. It's a way that we can really tackle this problem, and it's going to be good for 2022 and every year beyond. It's scalable. Important.
So I have been talking about RPA for the last 5 years. When RPA was started introducing, people started thinking, hey, it's going to limit the jobs, the back office, everyone, because hey, it's going to reduce the number of jobs. But it is reverse now. It is increasing more opportunity. People are saying it, including every technology when it comes, there is always criticism will happen. Hey, it's going to, especially RPA. There is a reason why I'm talking about RPA, because it's doing a lot of your back office operation. I have seen live on multiple industries. It's really great improvement on the RPA side. Thank you, Natasha. Quickly, I'd like to jump on to Jay with directly one question. So what are the
chime in on what
yeah, please
just
go
said real quick? I think that's a good point. What I want to impress on everybody who's joining in today is to be mindful of any additional workload or burden that you might be introducing through the use of your technology. I think like what Natasha is doing, and folks that are trying to optimize and make the operational space more efficient. In some ways, it's an easy way to get around some of the regulatory challenges of some of the more difficult clinical applications. The need to improve healthcare is really more on the operational side. If we're talking about $3.5 to $4 trillion of spend in the U.S. on healthcare, close to $800 billion, a quarter of that is attributed to administrative waste. 10 cents on every dollar actually goes to a clinician. So if we can cut out some of the waste in the system by optimizing and making the operational aspects, administrative tasks more efficient, that's where I think RPA holds a lot of promise. But again, we can't introduce some of that stuff at the expense of the patient's experience or the clinician's experience.
True. Agree.
Can I add one more thing on there, and kind of bringing it all the way back from the decision support tools, to just maximize CPT codes, like obviously is not the right thing to do. That means we leave out some patients because not everyone has the right CPT code to get billed for that. And so with Natasha saying, like, you can't replace the person, it needs to augment that. And so if we have a great NLP to do a good decision support, to make the right patient get the right thing, and then build that properly, now we get a great flywheel that's going to be humming and take care of all the people that need to be. And then other that aren't using the AI for all those things can take care of the patients that don't quite fit into that yet. And so we can see how the flywheel can spin, and we can start to add more people to the flywheel so we can get equitable care for everybody. So all good points.
And I think maybe to try and tie in John Archer's question from the chat too around federated AI, I'd like to see if anyone else has an opinion on that.
I would like to come on that, Rich. The questions will be taken a little later. So let me cover some of the actual questions first. I'm keep reading the side note of the questions. There's a very interesting questions are coming. Let's go for it, okay? But before that, I would like to first take some questions to about the healthcare data. I would like to take Jayo on this one. What are the additional challenges you face when you work with healthcare, health data in particular, especially on the particular things?
Yeah, we've touched on some of this already today, but I think a lot of the problem stems from just the fragmentation in the field, and that while there are definitely heroic efforts on trying to increase interoperability within the field, today we are in a pretty fragmented system where it's hard for a lot of the different data sources to talk to each other, to be joined with each other. There's a lot that's still unstructured. I mean, we're still getting records and sometimes that are, photocopies of PDFs, right? It's just a field where we're trying to deal with a lot of the historical data not being collected for the purpose that we're using a lot of that data today and trying to clean up some of that data. But it's also a field where that historical view across a patient's history is just so essential to understand kind of their health journey and continue to treat them. So it's not that you can kind of just start from the data that's being collected today and move forward. And so as a result of that, there's a lot of error in the data that we have, difficulties in kind of connecting those histories across patients as they've moved through different healthcare systems. And different pieces or nature of data in the system also tells very different stories. So, for example, there's a pretty big wealth of data within clinical billing claims, so clinical and pharmaceutical claims. And so they kind of tell you, if these are all the things that have been billed for, you can kind of piece together a history of the patient's past. But what that data does not tell you is the actual result of any tests or procedures that are being billed for. So, you might know that, I don't know, like an A1C test has been ordered, but you don't actually know the result of that. And so it's a partial story. And so you kind of have to put together a lot of these puzzle pieces together to get the full patient story. And in doing so, making sure you're not kind of accruing the error that's associated with all those joints and connections.
So great answer, Jayita. As we are a little bit shortage on the time, a lot of questions available. I have one very interesting question which I have to read now to go for my questions. What are some of the unique challenges in doing AI on health data, such that you cannot just apply what has been developed by other industries? It's very nice question, because we are thinking about AI is pretty common, but it's not. But what is the uniqueness? Who would like to take it? Jay, who would like to take it?
Sure, I can take a start. So, I mean, there's different challenges in every industry, right? A lot of, if you just look at where a lot of the maybe state-of-the-art data science companies in the tech industry, a lot of them are actually operational companies. A lot of them have the luxury of collecting their own data, and that is the data that they're then performing a lot of the AI on top of. Something that's nice in that model, so for example, Netflix collecting viewership data or Google collecting search data, et cetera, is you have a lot of control over how that data is collected and stored, or even what data you're collecting in the first place. What makes health very different is that it is not just one source of data or even one type of data or one party collecting the data. And so per the previous answer, that adds a lot of challenge into the system. A second challenge that we've also already discussed is the need for like intense security and privacy and ethical management of the data that we're using. And then a third, which I think we've also already touched on, is that there is a very unique taxonomy that sits on top of health data, and a very specific know-how that sits within the clinical world, but you really need to tap into their specific training to understand the meaning behind a lot of the data that is collected. But yeah, would love to hear from others of what the additional challenges are.
Yeah, I think too, all of those are very valid points. And while we've made tremendous strides and lots of evolution in AI, RPA, all of the machine learning, et cetera, there's still so much more to be learned and things that can be improved significantly. When we look at OCR specifically, it's good. It gives us some, but it can be quite the challenge. I don't know how much experience you all have with OCR, but that's definitely the Achilles heel for us.
Absolutely. Rich, Ty, any points about this one?
Well, I mean, it just from the beginning, I said, picking specific problems to maximize a solution for. And so if someone has a really big pain point with this one thing, character recognition, it's get from old PDFs to new stuff, whatever the big pain point is, if you're going to put enough resources, you collect the data and improve that. And so, as you said, there's so many things to work on. It's sometimes you can get a little intimidating, but pick something and improve it.
Absolutely. So, Mithul, I don't know whether did you hear the question or not. I'm really expecting, based on your product and the industries. Did you hear the questions, or do you want me to repeat?
No, I'm sorry. I've been having connection issues. Can you repeat that again?
So what are some of the unique challenges in doing AI on health data, such that you cannot just apply what has been developed by other industries? Because Natasha and Jayo, they mentioned that yes, definitely it is on the, you cannot, privacy of one thing definitely is there, right? That is a very important uniqueness for healthcare industry, none of the other industry have it. So yeah, please go ahead, Mitchell.
Yeah, no, I think it was mentioned earlier, and I'm not sure who mentioned it, but just in terms of human error, we receive a large amount of image data plus metadata, we use both elements to be able to train our algorithms. And what is required, in order for us to be able to validate what we receive, we don't take it at face value. We need annotators. We need individuals who can actually validate, and oftentimes a panel of individuals, specialists, oftentimes physicians, looking through that data to actually be able to validate what we actually have in the diagnosis that's being provided. And so, the worst thing that we can do as individuals, professionals in the AI sector is introduce products that is, we're getting garbage in and we're providing garbage out. We need to be able to take the time to be able to actually annotate, be able to validate what we're actually training the algorithm, and to be able to provide that diagnosis or prediction score or whatever the metric might be, so that we have we have assurance, we're gaining the trust of the physician or the lab technician who are using the product. I think Rich was talking about black box and the kind of spooky terms of AI just in general, and there's a lot of negative terms that are associated with AI, and so as professionals, we have really our opportunities for our first impression, and that's going to be really important that we get this right. And so by providing products that address and garner the trust of physicians and others who use it is going to be really important.
Perfect. I think we are reaching the time of 10:30. I'm going to start with more Q&A session going forward. Before that, Rich, do you have any points to cover to move on these questions, or should I proceed?
No, not on Yeah, and I think that was all really good. I think, I was going to try to go back and just touch on, because I know we were very much focused on healthcare delivery space, and Chatri, you were asking kind of upfront about, well, what about life sciences, and Arun kind of chimed in on that as well, and that's honestly where SaaS has been much more focused in the past years. And we're seeing explosive growth. Every clinical trial goes through SaaS's AI platform to validate the clinical trial when they submit to the FDA. And what we're seeing now, and all of these life science companies and pharmaceutical companies, in addition to helping with things like supply chain when COVID kind of first hit, now the topic is around virtual clinical trials and real world evidence and digital twins, particularly. So this concept of digital twins, I think we're seeing evolve in the life science space. It's going to become and very much be applicable to the healthcare provider and delivery space as well. So just a couple of things to look out there as far as how we see some of these industries and sectors merging.
Yeah, especially when you talk about this digital twin, four more technologies are really booming in this healthcare side. One is definitely AR, VR. Lot of augmented reality, virtual reality is going to boom, and definitely the other thing is, metaverse is part of it, is coming up very fast, picking up now. And the second thing is definitely a digital twin. Digital twin is picking up a lot of space in the healthcare side, which I'm seeing we have been working on some projects. And the other thing is blockchain. Blockchain for the security aspect, a lot of companies are trying to bring blockchain into the system, how they can secure the compliances. So that is one of the security aspect point people are trying to embed the blockchain. Some of this technology are really booming into this industry. Apart from all, in cyber security space, for especially healthcare, to avoid the hit, AI is really helping a lot. That is also going really well. I think a lot of new technology is evolving, but at the end of the day, the core system, AI intelligence, is very important for blending with all these technologies. Sounds great. Let me go with the questions. Let me take Arun Bol. He pinged the question. Could you share your thought on regulatory landscape on AI in medical devices? Who would like to take it?
Well, I'll just go back to the thing I kind of mentioned before on the radiology piece. It was really tricky because if we really want to leverage machine learning, we want to have a continuous training and let it learn. But there's obviously some risk to that if the guardrails aren't predefined. And so the original FDA approval processor had to have a specific outcome based on what your training and testing data was. And so people in the industry feel like that's pretty slow. Like how do we get faster if we have to keep applying for FDA approval? So hopefully they're getting better at that. But obviously, as a patient, like I want to be safe too. So just from the radiology part for the FDA approval, like I know that there's some push and shove and pull and push from all areas, and it's just so new. We don't know. I mean, we have to figure this out. We're figuring it out as we go. So in that space, I know that there's grumblings on both sides to make it faster or safer or both. So, but as far as other ones, I don't have enough. I'll have to defer to other people on the call for that.
Any other points? Regulatory landscape on AI in medical devices? Any other point from anyone?
Yeah, I mean, I can just add. I think this is a classic case of where software and innovation thought process is ahead, and maybe many years, if not longer, just in terms of how the regulatory landscape is actually keeping up with innovation and with how fast AI is actually moving. Radiology space, similar to Ty, that there are some amount of clearances, at least from the FDA perspective and CE, IVD perspective, just in getting products out into the market, AI products out into the market. And I think that hopefully paves the way for other types of AI products, specifically in pathology, which Proscia is involved in, that it sets leaves a precedence for how testing, how performance testing, how validation actually can occur. It is slower, but I feel like there is progress, at least in certain sectors of the healthcare industry.
And I'll tell you that these agencies are trying. They are mindful of that. They're trying to speed it up. SAS works very closely. We do a lot with these agencies. And they're looking at ways, okay, well, how do they start thinking about and how can we build systems, leveraging AI and RPA and all those things to help speed up those processes as well. So that is happening. It's just happening at a government's pace.
Sure. Team, I think a lot of audiences are pinging in discussion as well. Please, if you have questions, please type that in the Q&A session, because I'm seeing both sides of Q&A. Please type in the Q&A. Okay, let me take the other question. What are your thoughts on clinical decision support and NLP? Who would like to take it?
We sort of did that one a little bit ago.
Sorry?
We talked about that before.
Yeah,
Oh, sorry. Okay. So, could any of the panelists touch on how specifically AI is impacting real time in rehabilitation and maintenance of the patient as it relates to physical therapist and serving as a patient advocate?
So I haven't done it specifically. It seems like they want some real specific stuff. But what I can say is I've seen a few that use machine learning to get body positioning. And so what that is helpful for the physical therapist is range of motion. So if you say your shoulder hurts and you do your little thing and you're like, oh, 90 degrees range of motion or 120 or 180, like those are data points that the physical therapist can use. And possibly there's other data points they can capture. But I mean, if you just Google like, physical therapy AI, there's a few of them out there and you can see what they do.
Anyone else?
Yeah. Benjamin, I'm glad you asked that question. My wife's a physical therapist. And so in particular, I've been watching the space around rehab and physical therapy, a discipline that historically you thought would always need to be in person. When COVID hit, we forced a lot of change, right? And the glue that held the system together is no longer location. And so she shifted and she focuses, let's qualify that. She focuses in geriatrics and falls prevention and Parkinson's. And she shifted the way she practiced into delivering physical therapy remotely. She loved it. Her patients loved it. There were connection challenges, sure. Her outcomes were improved because now she was seeing them interact in their home environment. I think what Ty is mentioning around being able to layer on something to help her do some of her assessments. So when you're trying to evaluate range of motion to get down the precise degrees of which that might be changing, that is a little difficult to see through video. But there are AI applications that we've been working on with clients, as well as some of the companies that are up and coming in the space. The one I think of is Hinge Health. There's a couple others out there that are doing work in this space. And honestly, I and my wife don't feel threatened by that. Again, it goes back to this notion of top of license. If we're predicting huge shortages of clinicians, I think it was 13 million or something by the World Health Organization by 2033 or something like that. It's all about what can we automate and then what can we then triage up to an actual in-person visit. Who needs to be seen at the clinic for the more complex cases? And so that's where I think Jayadita and what she's doing in her company then becomes very valuable in helping route that care.
Yeah, there's a post-prediction. A lot of post-prediction algorithms are there, open post, multiple things. They're also using this one. Yeah, please go ahead.
And then the back end of that, when we talk about physical therapy, the AI and RPA and some of those other things that we're looking at also gives us the ability to look at how many timed procedures, how many modalities until the patient has been treated, how many, usually when we're requesting authorizations, we're requesting for, 11 to 16 visits at a time. And so when we have bots that are able to go ahead and get those authorizations in place in advance, then we're talking about, yes, the shortage in clinicians, but then also the shortage in the back office and the cost savings and being able to automate that piece.
And then just to add on to the comment made by Rich, it's exactly that, right? So I think there's a lot of good AI being used like in the actual physical therapy and the treatment aspects of things, but also in the routing aspects. So for example, within Included, we both deliver virtual care, but also route members to in-person care. So we use our algorithms to understand when is a patient more suited for one form of care or another, or even a combination of the two. We also both route between, so we actually recommend members to go to Hinge, but also could recommend members to go to a PM&R or a physical therapist, right? It's also a decision point of, how do you route yourself through these various options that might be available.
And the last comment I might make, just because I've seen a couple of people who are in the payer space, a couple of you from Olive out there, I see you, is to also be mindful of, this healthcare spend. Also, a lot of it is so focused on actual treatment and cure. And so, but when we look at the geriatric or the elderly population, oftentimes it's just about preservation of function, or less, right? Like we're trying to minimize the decline. And that, if I have to speak up for my wife, like that's the frustration. And so we can apply analytics and all these things to it, but she's still fighting, Natasha, right, to try and get approval for the next 4 visits, just so she can minimize the decline of the patient, but has to fight with the payer because they want to see a progression, right? And so there's still aspects around the system for that we need to figure out how to solve for and bring light to that even doing that is still, for the payers, are still financially beneficial to them as well.
Yeah. And I love that it comes full circle when we talk about, each one of us is taking a different aspect of the patient care. When we talk about just the physical therapy piece, for instance, how every one of us, it just comes like full circle. It's a cycle, and it's amazing that we can work together, share our thoughts, share our ideas. And then when we come together, that it puts, step 1 with step 2 with step 3, how we are navigating patient care and funneling them to the appropriate places, and then how we're treating those patients and being able to give them the care that they need, and then how we're getting the providers of care reimbursed for that. And I just really love the way it just comes full circle.
Okay, thanks for all of the answers. And the other question which I'm moving now is, anyone's solution today leveraging federated AI where the models, weights, parameters are shared and not the data?
This has gotten a lot of press in the radiology space as well, because it's much easier to send the actual pictures than all the surrounding DICOM patient data. But I do want to just add one thing, that while that's an awesome idea, like literally still I have written prescriptions scanned in asking for a CD of the MRI when they're done. And so the system in America, at least, is not ready for widespread federated data sharing. Now, in places in Northern California, Chicago, Boston, like they're making the systems to make the federated sharing like work. But just understand, like I'm thankful that I still get to see this ridiculousness on a day-to-day basis, so I don't get too far ahead of myself to think that we're ready for federated data exchanged now. So totally love it, and I would love to see it expand. But we've got a lot of work to do.
Yeah, it's amazing.
Go ahead, Natasha.
Sorry, just one sentence. So it's just amazing how many times people are still asking, what is HIE? And these are like the top level people at hospitals. And so I think that's important to remember.
Yeah, and I think what I was reading in John's question, I think he just clarifies, is asking more specifically around, is there an opportunity to federate the models and the actual AI algorithms? And I think the challenge there is every health system's data are structured differently, right? Everyone went in and customized their own EMRs. And so I would love to see that. Trust me, I think that would make a lot of our jobs a lot easier. But it's like every time you go into a client, it's a custom project to be able to have to customize that algorithm and tailor it to their data. Do I think there's maybe opportunity to kind of apply AI to that process? Yeah, absolutely. But I think we're a few steps away. I haven't part of the CompTIA Council, AI Council. So we have some discussion around this area, especially how to federate the models to share across multiple people. But it's when we had a lot of experts discussion, it's really not easy to go, but eventually one day it will be there. But if that comes, it's beautiful. I love this question definitely. Okay, moving to the next questions. Okay.
It is, sorry, I missed the name. John Archer was the one. Good question. With the next question is Arun Bol again. With evolving of AI in healthcare, how much it is going to impact on clinical trials? That being on-site clinical trial versus virtual clinical trials. Good question. Who would like to take it? I think it's more relevant to
I can take a stab at that. I think a short answer is yes. There's going to be a tremendous amount of impact that AI could provide, just in terms of where AI can crunch data, be able to provide gather a large sum of data, and be able to provide a distilled version, filter of information that's relevant for pharmas who are running clinical trials, to be able to be really precise in being able to reach out to the right individuals for that clinical trial. I think what happens right now, or what has historically happened, is that there's large sums of individuals that are at the end of the trial probably excluded out. So where companion diagnostics and where AI can actually take that information, actually provide the pharma company or whoever's running these trials a more distilled and specific, and a predictive element to be able to not only choose the population that's going to best succeed for this trial, but also be able to make a prediction based on assumptions and some evidence that, here's what we're predicting, just in terms of where these individuals will actually yield in terms of this clinical trial. So I think companion diagnostics, specifically in the pathology field and in others, will play a very big role for pharma companies in their clinical trials.
And I think bringing in new types of data, particularly social determinants and those types of data into clinical trials, is critical. And I think this is also where we tie back into that notion of the digital twin, right? And so if we can reduce the trial size as we get better with generating synthetic data and creating digital twins, no longer do we have to hold out this section of the population that we're going to give a placebo to. We can try everyone on the new therapy and then compare that to a digital twin for the placebo comparison, for instance. There's a lot.
Synthetic data is not going to be that relevant because there's more health data, right? Because if you talk about other technology, makes sense to me, but it's more health-related data. Do you think the synthetic data will really helpful here, that bring the accuracy, the testing?
Yeah. The short answer is yeah. And all the pharmaceutical companies that we're working with say yeah.
Okay. Sounds great. I have $1 million question, okay? So I don't know who has answer for this one. When COVID will end? Who has the answer? I don't know. Any kind of prediction? I know you guys have been working.
We're into new normal, right? I mean, I envision this thing coming to something where we settle into a norm where we kind of treat it like the flu. We're going to see multiple variants continue, but I think the lesson in the severity. This is just me speaking. I'm not speaking right on anyone's behalf, but just kind of the way my perspective is. That also just means, right, that we've just got to move forward as if this is the new norm, and then let's be pleasantly surprised if not.
Okay, it's going to continue. The answer is it's not going to end. It's continue like a flu model. Okay. The new variant, my Omicron, is a very less impact version because it's losing its power. I see that because I faced it. So I'm luckily faced Omicron, not the original COVID variant. Okay, there's no answer. Continue it. Okay. Let's move on to the next question. I definitely like this question written by Hedi Razavi. How do you say AI helping chronic health illness? It's a very tricky question too from my view.
So I mean, I'll just kind of swing back in. Like, you got to pick the specific disease. So congestive heart failure, like, how do you get the fluid out of the lungs? Like, you got to pick the disease and pick the problems and maximize for. So many companies are doing a really great job of doing that. Scales in the home to see if they're gaining weight, to see if they're retaining water, that it could be CHF. And so I mean, there's many silos that are working to get these specific diseases under control, and then we can hopefully connect them all kind of at the end. But yes, we can, and yes, we are, and we have a long way to go.
I will add to the fact that AI is kind of playing into the actual treatment of aspects of chronic health illness. We sit a little bit upstream of that, trying to use data to identify just which members could use a longitudinal care plan to help with management through their chronic illness. So, who might require more frequent medication reviews, who might require kind of check-ins around behavioral health status, et cetera, as they're working through the management of the chronic health illness and making sure that we're pairing them with the right type of professionals to check in with them regularly.
Got it.
It's a critical thing and a critical lens for the patients to consider. One of my colleagues is an actuary, and so we work very closely with a lot of the major payers. And so when we're looking at risk modeling in particular, everything that we're talking about and all these new fancy digital virtual ways to deliver care, we can't necessarily just make that available to everybody because everybody doesn't need it. There's a place within their healthcare journey in which it makes the most sense. We don't want to deliver something too early, and obviously we don't want to deliver it too late either. So AI playing a role there, and again, that's why I get excited about companies like what Jadida is doing to helping navigate that and identify when at the right moment is it time to intervene.
Sure. I think we have 8 more minutes, but I would like to give a space to all of the speakers. Do you like to bring any special question in this panel which you are really interested to bring in?
I think we covered an amazing amount of ground in the last hour. I've really enjoyed it.
Yeah, there's a lot we are covering it. And there's still one question I would like to take it as well. What are ways you can use AI to improve diversity and inclusion in healthcare?
Well, for one, just capturing more granular data is helpful. We touched on like zip codes is one way to know, but we know that there's disparity, and we know that there are large areas that need improvement, and that could be based on all kinds of variables. And so I think we need a little bit more granular data, and then we need to align incentives to improve. And so hopefully by collecting the data, we can start to at least uncover where we need to work.
And I think if we look at the first speaker of the day, right, where we have the deaf community and some of the AI technologies that specific companies, to Ty's point, pick your niche, pick your market, be really, really great at what you do. And then we come together like we are today and we share the information with one another and kind of bring it back together as a whole. But I think, just like that first speaker that we heard from this morning, in that one particular market, they represent something really important. And while I may not be as well versed in that, I know that they're handling it. They're doing a really great job, and that we get to learn from that. We get to benefit from it when we come together. It's just really great.
Yeah, I would like to take a moment to thank Greg as well. Really, I'm very impressed the way he presented today as a group work and confident. I really want to, I don't know whether he's there or not. Thank you so much, Greg, on joining and presenting a wonderful session and the way you presented. Yeah, please go ahead, Jay. Yeah.
+1 to his talk. So one way in which we think through diversity and inclusion is, so traditionally as a company, we spend a lot of time trying to use longitudinal provider data to assess provider quality. So which providers are more safe at performing or treating a certain patient population, which providers have more of a experience in different areas, track record of kind of delivering clinical outcomes for different patient use cases. As we extend that problem, I think subsetting it to different subpopulations and communities kind of split by different demographics is an interesting way of figuring out kind of which provider pockets are going to be best at treating different groups in more inclusive ways. So for example, a subset of our company actually manually went through and had a very, very stringent process of calling doctors' offices and finding out what they treat and talking to patients who've been there to understand which best treated the LGBTQ plus population. And through that, we got this massively manually curated, you can call it a trading set of which providers, have helped make that group, feel like they're getting equitable care. We can then use that type of data to see if we can find additional patterns through it, kind of grow that and see if we can kind of continue to understand which providers are providing, quality care to different types of populations, and try to make sure we're routing, again, those patients to places where they're going to get the best care for them.
Great answer. The last question before I close this, especially on the RPA side, what are the use cases that are most successful for RPA in healthcare revenue cycle management? Natasha, would you like to take it?
Yeah. So a lot of them have been around payment posting. We know that with the importable 835 data files, we have seen a lot of that is kind of automated, but there's still a very manual process at the end of that. But then when we talk about paper again, so we've got all of our claims go out on a standard HCFA 1500 claim form, right? Or it goes out on the 837 data set, or it goes out on the UB claim forms for facilities. So those are the three formats that you can send it. There's nothing else that's acceptable. But when we look at EOBs that come back from payers, every single payer has a different format that they send it in. And then the provider's office has to take all of those, 8,000 different formats and somehow get it all into their system in one way. And so that's been a challenge for all of our clients. And so we've been able to use both OCR for turning those paper EOBs into 835 data files, or using robotic process automation. So payment posting has been hugely successful. But then when we look at denial appeals, and they're handled one by one by a team of 200 to 500 sometimes users that are just appealing those denials. So if we can put together a data set of rules when it's denied for this particular thing and it's for this particular carrier, and we know exactly what they're needing, go and obtain medical records, print it to a PDF and either upload it to the payer portal, e-fax it, or print it in the middle of the night so it's not holding up the printer for the users during the day, those types of things. Like I mentioned before, eligibility, authorizations, etc.
No, I'm really scared that he's taking away my job. Okay.
Oh no! No, supplementing. We always have to have that element of quality, and there's always going to be exceptions. And then I think something that's really important for the healthcare community to understand is that now we are elevating the knowledge and expertise of the users from a data entry type position to now they're managing these processes. They're managing the bots essentially, or these digital employees. They're making sure that everything is running smoothly. If there's something that's not working appropriately, they're auditing it the same way that they would have performed the function to begin with. And so it's really important to know that we will never ever get away from that human element. It's absolutely imperative, but it really helps us to be able to keep up with the volumes when we've got so many variances and variables in healthcare.
Thank you so much, Natasha. I think we are up to the time. Thank you so much for all of you joining this call, and it's a wonderful panel discussion, sharing all of your thoughts and wonderful information as well. Thanks, Nitin, for inviting us. Looking forward to seeing you all.
Thank you.
Thank you so much.
Thank you, Chitray, and thank you, everyone, all the panel members. It was a lovely panel discussion, and I thoroughly enjoyed it. Hope the audience also liked it. Thank you. Thank you, everyone. Bye. So we'll quickly move on to our next presenter. So, guys, just to let all of you know, we have 4 great talks in line after this panel discussion. So the first talk after just the panel discussion is by Matthew, who is Senior Director of AI in Optum Technology. His topic is the cutting edge of AI in healthcare. So over to you, Matthew.
Good morning, everyone. And what a great panel. Just to give kudos to all the folks who are on the line having that wonderful discussion before I was sort of a bug on the wall. Welcome to all the folks who are in the audience. Coming to you from Minnesota, where it's minus 17 degrees here, wind chill. So if you ever want a cold place to be, Minnesota is definitely the area to be in. I'm just going to share my screen here and we'll get started. Whoops. Looks like I went on mute here. Can you guys hear me?
Yes, we can hear you, Matthew.
Okay, good. I just wanted to check that. All right, I'm going to share my screen here, and we will get started. I'm presenting. Going to minimize this, and we'll hop right on to that and get right started. So what I'm going to bring to you today is what I call the cutting edge of artificial intelligence in healthcare. We're going to look at things like what do we think of AI? What are the most important use cases that we see out there? And then what are the real cutting edge use cases out there? Let's just take a look at our agenda here. We're going to level set on what AI is. We've got a whopping 20 minutes to do this. We're going to look at what the existing trends and technologies are, older stuff you might not be aware of, newer trends, new stuff, and then we're going to look at the razor's edge, those things that are really on the cutting edge, and then references. So that's kind of the agenda today. What we'll do is level set on AI. Most folks think that AI these days is data science, machine learning, neural networks, and deep learning. They couldn't be more wrong. Think of the smarts that would be in a robot that will have to walk around your house, do your laundry, clean your house, cook your dinner, walk your dog. What are those AI theories? And that's all of this other stuff here. The data-oriented part of AI is just a small part. There's a lot of other AI like robotic process automation, intelligent agents, cognitive technology, things like that. Reasoning systems, perception systems, and all that go into playing in that space. And hopefully, okay, you can hear me. It just sounded like we had some audio problems there. But we look at AI as a larger picture, and a lot of times we'll go into other industries like the defense industry and other academic industry and lift and shift AI to help solve some of these really difficult, especially clinically difficult problems out there. So we also look at AI as a portfolio of other things. You get your standards, data science, machine learning, deep learning, reinforcement learning, knowledge representation, which include graph database ontologies, knowledge graphs, and all that. RPA, all the language stuff, including natural language understanding, which is really kind of in its infancy right now. We are also going to look at chatbots and intelligent assistants. We will look at vision systems, intelligent agents, reasoning systems, and complex event processing as well. Let me know if my voice you can still hear my voice.
Yeah, it's perfect, Matthew.
Okay, good. I'll just carry right on. And so we'll just pass by this a little bit. One of the things that we look at when we were examining the AI space out there is the coverage of AI based on some of the key aspects of utility out there. And we noticed that there was a real lacking of the AI toolkit in terms of the need within the healthcare industry. And you can see that by the white space here. And I think that's really what this diagram shows, that our current toolkit is truly inefficient to handle everything. It needs to grow. It needs to get better, even of all the technologies we have now. But keep in mind, we'll have this portfolio approach as we look at existing trends and technologies. So let's look at these. There's a few of these at note. We'll take a look at aging, patient personalization, precision medicine, smart hospitals, EMR, all the way down to drug development, clinical trials, and Internet of Things. And then this is sort of the stuff that's already out there. So aging, chronic, end-of-life care. When you look at over here on the left-hand side, this is sort of a mnemonic portfolio of the AI capabilities that exist in this space. This is when people are living their last days, last year, last month, last week, last days. The aspects of the business case here is enormous, and human value is infinite. The ability to have AI make this process more dignified for the family, for the individual going through it, and many other aspects of it is tremendous. And what a space where we really need to have have coverage here. So this is a large use case. You'll see lots of things from ambient computing to machine learning to just data science to all kinds of other things in this space and playing well. Patient personalization and precision medicine. One size fits all medicine is really what we have right now. And that's not going to work. It doesn't work now because some people actually get benefit down here. Some people get none. Some people get worse because of that. And what we need is a way to combine all aspects of health, from your genomics to your lifestyle choices to your population health, and really meet people where they are. It's an enormous business case. The human value is absolutely huge. It's just another one of those areas that you're going to see lots of AI portfolio capabilities playing in this space. Smart hospitals. This is one of the things that really excites me. When the hospital itself, everyone, including the health, the care staff, the patient, the supply chain capabilities are all censored and hooked into an artificial general intelligence. What happens is that the domicile itself becomes part of the care plan or care team, monitoring everything from the patient's environment to the health of the care team who's delivering care to that person in their well-being, as well as external supply chain concerns and things like this. You'll see smart hospitals, smart cities, smart houses, many of these things. This is a wave of the future. It's a massive area, huge business case, very significant human value as well. So look to this to be a real thing moving forward. EMRs are a big thing. We just can't get away with it without it. And all of the technology that goes from establishing that, pulling data, massaging data, changing data, monitoring data, having capabilities of monitoring on the patient, in the patient, and wearable by the patient. These are all in this space to do that. Enormous business case, lots of money there. Human values is significant. Look to this to be one of those other areas where it's just going to grow and grow and grow. And the whole portfolio of AI will fit in this space. Everywhere care. So the right care at the right place at the right time at the right cost, and actually the right care to make that person healthy. $23 billion market. By 2022, they're expecting 102. CMS is now paying for virtual visits, and what that means is that the money changes. They weren't paying for virtual visits now, previous to this, and COVID changed that for the better. But now this is a huge market, and everyone is going to establish a digital footprint in this space. We are as well. It's an enormous market. It's one of the ways that healthcare will mature and help get fixed in this area. So look for everywhere care. It's going to be a big deal. Drug development, clinical trials, AI plays a huge part in this. Everything from genomics to corralling together the patient population, and it's going to continue to play a huge role here. And you should keep your eye on that as well. Genetics and genomics, we've already gotten patents through in the quantum space with genetics and genomics. You're going to see this as a major area, especially when it comes to patient personalization. We have to get down to this level. Augmented decision-making is an enormous issue, especially on the clinical side, because clinicians, the FDA looks at machine learning models and says that's a medical device and we will rule this. We will govern this. But this is such a big area, and this is where we'll look at cognitive technology to come in and play an augmentative role in the clinically facing space, such that the human's always in the loop, and the AI is simply informing the doctor, not replacing them. That's an enormous thing. The FDA looks at that and goes, hey, that's okay. So if your AI replaces the doctor, you're going to have to deal with the FDA. If your AI augments the doctor, the FDA does not care. That's an enormous strategic aspect.
Hi, Matthew. Nitin here. Can you just move your this one? There's a hide in the screen which is showing there. Can you
hiding there?
Yeah, now
there
it is
we go.
Okay. Thank you.
Thank you. All right. So carrying on, this is a huge area, augmented decision-making in this space. Here's the real winner here. Anywhere AI can do wellness to keep people healthy in the route to virtual care, as opposed to healing people once they're sick, that's where the big win is going to come from. You're going to see lots of money being poured into wellness, everything from the smart cities to smart homes to smart healthcare to smart devices. Everywhere, it's an enormous market, lots of AI in this space, and that's going to be a major player moving forward. Internet of Things, I'm going to pass over because we're going to get to Internet of Medical Things later on. It's a huge business. I'm going to pass it now for now because I want to get into newer trends and technologies. We've got a lot to cover here. So we'll look at intelligent agents, simulation, mobile healthcare, all the way down to fraud, waste, and abuse. So intelligent assistance, I think, is going to be a thing. Now, this is not a chatbot. There's a spectrum here. Chatbots are kind of dumb parroting things that make it look like they're intelligent, but they really have no idea what they're doing. Intelligent assistants, aka something of the order of Cortana's, Halo's Cortana. She's a character in that series there. Is what an artificial general intelligence is that can monitor everything and make suggestions to the clinician. And that is what we call an intelligent assistant. It's not yet developed because the technology is not there for it. And don't let the NLP people fool you to think that, oh yeah, this is going to actually understand what it's doing. There's nothing on the market that actually understands and can reason over an interaction just yet, but there's a lot of good tech that's moving that way, a massive area of technology that fuses together. This is where you see new technology being born of fusions, very large business cases, significant value. This is where we can do mass personalization on a huge scale if this moves forward, but this is not yet a thing. It's becoming a thing, so keep your eyes peeled for this. Simulations. This is a neat area that we're getting into. There are certain things that you can't do in real life because it's either too expensive, too dangerous, or prohibitive. And simulations allow us to take large-scale economic healthcare concerns and model them out. Everything from pandemics to economic concerns, and then you can tweak sliders to ask business questions or clinical questions at a mass scale of this thing that you've just created. This allows us a tremendous advantage in understanding what our policy decisions are in lieu of what our clinical concerns are, or economic concerns, operational concerns, lots of different areas in the healthcare space. And so look to this to be a major issue moving forward. Mobile healthcare is a thing. I'm going to pass over this because we've kind of talked about this already. But healthcare ops is a real issue where all kinds of AI can come in. It's a horribly inefficient system right now. We're wasting tons of money, 17% of GDP. We have to get healthcare ops under control, and the way that it is created and executed, we've got to get the CDOs to work a lot more efficiently and cut costs out of the system. This is really key. So this is going to be a major area. Lots of technologies can play. Keep your eye on this. Business case is gigantic. The human value is immense as well. And so there's all kinds of other reasons here that healthcare ops needs to be something of under the microscope. Internet of Medical Things is amazing. There are wearables, there's injectables, there's stuff that goes under subcutaneous tissues, there's stuff you can ingest. You have to look at the human body as a computational platform. When you look at AI, there's two things when it comes to this space. Number one, AI is a general purpose technology, which if you look up GPTs around the world, they actually massively change the landscape across the world, like the steam engine, domesticated animals, combustion engine, light bulb, that kind of thing. And then the second thing is looking at the human body as a computational platform. It's not just the object anymore. It's the thing where computational capabilities can sit on to monitor someone in real time so that those real-time trends can be evaluated by a doctor rather than snapshots here and there, because the trends are what allow us to understand the health of an individual. So there's a massive amount of different types of AI in here. That's this sort of mnemonic over here. And there's all kinds of areas where those can fit together. And you've got AI on the edge, in the middle, and at the doctor's office, and at the level of server, all kinds of things down here, and two very large areas for business and health. Smarter hospitals, we'll just pass through that. Graph databases. If you're not looking at graph databases, you need to understand the impact of graph databases within the medical space. It's got a rocky start, but it's a hugely powerful technology. we're doing quite a lot with it. You really need to have your finger on that pulse as well. That's going to change things for the better. And in many spaces, as a matter of fact. Behavioral health, the most expensive part of our healthcare system right now, overtaking coronary and oncology, which most people don't know. And now that CMS is paying for virtual visits, now you've got the digital aspect of behavioral health across the spectrum. This is a huge business case, and it's the most expensive part of our healthcare right now. And there's lots of areas in AI that could help, from medical, from early diagnosis to utilization management, all across the board. This is an area where AI can fit in there. There's lots of books out there that can articulate what's going on under the hood. So keep your finger on this one. This is a big one. I will go past this. Fraud, waste, and abuse, just to kind of touch on things before we move forward. It's a huge area. It's got to get taken out. So we're going to look at the razor's edge. Two aspects in the next 5 minutes: cognitive technology and quantum computing. Cognitive technology is one of those things that says, hey, let me just go to this one slide. We're using the SOAR cognitive architecture, but if you look at the brain, how it works mechanically, you've got discrete areas doing unique tasks, right, that are highly intertwined together. And that gives us something that we take for granted: human cognition, attention, memory, judgment, problem solving, decision making, that kind of stuff. But software frameworks were designed to do the exact same thing: discrete areas doing unique tasks, highly interconnected, that give us computational cognition, these same human cognition capabilities in a software framework, open source, that we can use in the clinically facing space as an augmentation AI that's not like machine learning or deep learning or any of those things, that solves all kinds of problems in the care plan, triage, and assessment space, because it can reason over a case autonomously and deliver clinically accurate results. This is very helpful, and this is an area that's being ignored, along with intelligent agents and things like that. So I won't belabor this point, except that it's a true third wave AI technology. You've got traditional programming, neural nets, and cognitive architectures here. It's really something completely different, and it should be on your radar if you're in the healthcare AI space. Quantum computing. This is really going to be bleeding edge, but this is happening. We're doing this right now in Optum. Quantum computing basically says, hey, we're going to take your classical bits of 0 and 1, and we're going to swap that out with subatomic particles. Instead of doing stuff in vacuum tubes and silicon chips, we're actually going to be doing information processing on subatomic particles like photons and neutrons and whatnot. That gives us all kinds of crazy good things, like these: quantum waves, qubits, superposition, quantum interference, entanglement, and teleportation. It does things differently. It calculates and it computes differently. And this allows us to do all kinds of stuff that you simply can't do in the classical world. And so we've been spearheading this for about 4 years. We've got a number of patents out there. This is a space you have to have your finger on for many, many reasons. But there's some drawbacks. Quantum states are fragile. There's decoherence. You can't copy variables, all these other technical things. The result of that is that at this current state of maturity in the quantum space, there's only a certain small type of narrowly defined problems that you can actually solve, either ones that are quantum friendly or force friendly. However, there are some loopholes to this. I'm going to go past this for a second. One of those loopholes are, aside from the stuff that's quantum friendly, is if you take a problem, and let's break this up for a second. If you take a problem and you can break it up into quantum friendly versus classical friendly, then you can break up many of these sub-problems into areas that quantum computing can help in. And that opens up the aperture of the types of problems at this stage of quantum maturity that we can solve. And so this is going to be a real rich area. The two areas that I know of that are the richest for quantum computing as well as cognitive technologies are the defense industry, who are definitely using it, and on the more laudable end is the healthcare industry as well. So keep your eyes peeled at quantum computing. That's going to make a big difference, I think. And hopefully we'll see that. I expect us to see that in our lifetime. So if you're not having your eyes peeled on quantum and cognitive, you should. They're cutting edge that are going to put you ahead of the crowd, I think. And that is it. So at this point, I can stop sharing and turn our efforts back to our presenter.
Thank you, Matthew. Thank you. I think it was a lovely, lovely, lovely presentation, and lots of data was there. I think it requires around an hour, and yeah, to showcase what you have. But it was a lovely one. You covered majority of the things. Thank you, Matthew.
It's my pleasure.
Any question, guys, for Matthew? You can type in the Q&A section. Just to let all of you know, you can type in as and when the speaker speaks, so that easy for us to move. Yeah, Matthew, question. You can answer it quick because we are over time now. Have there been applications in quantum computing for healthcare?
Yes, mostly. Well, applications. So when you look at healthcare, you have to break it apart from life sciences. So life sciences are very aggressive in reinvesting dollars into their looking at molecules to develop new drugs. A lot of quantum in that space and a lot of investment. Healthcare, on the other hand, is a very conservative, financially driven space. And so we're not seeing as much investment in the healthcare space. We're seeing some patents. We've got a few in the genomics area. And we're seeing lots of POCs, especially on the security area, where we're dealing with quantum safe algorithms in the encryption space to help our enterprise information systems security do their thing and prepare for that kind of thing in the future. But you'll see more actual quantum projects at this stage of the maturity of the technology in the life sciences space, because they have very discrete and clear-cut applications. On ours, we're just kind of bringing up the rear a little bit and then trying to push people forward.
What quantum platform are you using, Matthew?
So we have we don't want to take a platform approach, because we have to maintain a platform agnostic space so that we can handle. There's two sides of quantum. There's the producers who make the tech, and there's the consumers who use it and try to solve problems. We're in that consumer group. And what we want to do is be able to have a broad understanding, a strong intuitive aspect of the key concepts, so that we can take anyone's platform and move it along. Now, that said, I mean, you've got Honeywell out there who's going to be a big juggernaut, and you've got IBM, you've got AWS, which really has a lot of capabilities under the hood. So there's some real good players out there. I'd keep my eyes on those big three. I mean, Honeywell Cambridge Computing is a real juggernaut out there that have come out of left field with some very strong capabilities. AWS is a monster out there. And of course, IBM is the 500-pound gorilla in the room.
Yeah. So last one. Are your updates limited to certain geographies? Matthew?
Updates. No, I think we're global. We've got presence in India, Ireland, and the US.
Okay. Yeah. Thank you, Matthew. Thank you for the lovely presentation. And yeah, guys, we'll share the presentation to you all. I mentioned in the initial stage only that we'll share the presentations with all the registered attendees who have attended for the event. Yeah. Thank you.
All right. It's been a privilege being here. Thank you for having me.
Privilege to have you, Matthew. We'll stay connected. Thank you. So, guys, we'll quickly move on to our next presenter, Gerardo, who's founder, CEO of ChartNote. Gerardo, are you there? Michael is there? Michael Rea? So, Michael, we'll have you. Michael is Director of Managed Care, Belton. Michael, you are the next one. Michael's topic is the social and economic impact hearing loss has on consumers and health plans.
Hello, everybody, and thank you for inviting me to present. I look forward to giving you an updates on hearing healthcare. Just a little bit about my background is I've been involved in hearing healthcare for over 25 plus years. And hearing healthcare has obviously changed in the last decade. That some of the information I will share will be quite alarming to you, because for the majority of you that are on this call, you probably assume that hearing healthcare is really for 65 plus. But as you're going to see with some of the statistics that I will share with you, is that the majority of people with hearing loss are below 65 years of age. And so today my presentation is on the social and economic impact of hearing loss on consumers and health plans. We'll talk about the growing demand for hearing benefits, the value of offering hearing benefits. And it's interesting because these type of benefits are usually not offered through medical. Usually people are left on their own when they need hearing aid devices. And so there is a growing demand for hearing healthcare. There's many advantages to offering hearing healthcare as far as expanded product portfolio, advantages for employers to offer this to their employee base. And then we're also talking about benefits that address important parts of healthcare that are traditionally outside the scope of major medical. Right now, by the numbers, there's over 48 million Americans that have some degree of hearing loss. Over 26 million people are between the ages of 20 to 69. Interesting is that 2 decades ago, the majority of people with hearing loss were really people over 70 years of age. They were usually males, people that were in wars or in manufacturing. But the reason why the younger population are impacted by hearing loss is just based on technology. If you think about technology in general, the iPods, the surround sounds in people's homes, that we're exposing our younger population to louder sounds than ever before. When I was growing up, it was typically, you'd listen to a boombox or you'd listen to the TV, but you didn't have the surround sound or you didn't have the gaming systems. And so hearing loss is starting to occur at a much younger age. Statistically in our industry, by the time somebody admits they have a hearing loss to the time they go see a hearing care provider, on average, it's somewhere between 5 to 7 years. During the 5 to 7 year period, people usually, what they'll do is they'll adjust their lifestyle. So if you ever walked into a living room, for example, and noticed that the TV is blaring, typically that would be a first sign that that individual that's watching the TV show at a high volume may have a hearing loss. Or if you ever see yourself in a situation where you're having a conversation with somebody and they're having to lean in to hear you, typically then you would indicate that that individual might have a hearing loss in that environment. Hearing loss is the third most prevalent chronic health condition facing older adults, behind arthritis and other heart-related issues. And again, what are some of the select risk factors for hearing loss? First and foremost, it's aging. So as we age, you think about with vision, for example, and I like to do a lot of correlations between vision and hearing because when we get into our 40s, our vision acuities usually decrease. That happened to me, for example. I'm having to wear eyewear for the first time ever in my life. Well, the same thing happens with hearing. So it happens over years, and it's based on exposure and some other related health issues, such as, occupational noises, where jobs where loud noise is a regular part of the working environment, such as construction or factory work, can lead to damage inside the ear. Other types of things that can expose as far as recreational noises, such as, if you're a hunter, for example, and you're out hunting on a yearly basis and you're not wearing ear protection, there's a likelihood that you're going to have some degree of hearing loss over, a period of time. If you're around jet engines, certain occupations will cause hearing loss. For example, people that are in the fire department or police, because of the sirens of those vehicles, a lot of them don't wear hearing protection. And then over a period of a decade or two, they have problems with their hearing. And so there's other health-related issues that can cause hearing loss too. For example, drugs, antibiotics, certain chemotherapy drugs can cause hearing loss, even Viagra. And again, these drugs, it won't happen immediately, but as somebody takes these drugs over a period of time, it induces hearing loss at some point. Again, about 80% of hearing loss cause can be treated with hearing aids, but only 1 in 4 individuals could benefit use them. Probably the number one reason why people put this off is stigma. They feel like it's a sign of old age, especially among the elderly. The younger population is more likely to adapt to hearing aids as they age. You think about our culture right now, people are used to putting things in their ears, whether it's buds or, surround if they're listening to music or, wireless Bluetooth technologies. That what we're seeing a trend in our industry is somebody is aging, they're more likely to adapt to these products. The other reason why people put off hearing aids is costs. They can be very expensive. If you've ever had friends or family members that have been treated for hearing loss, you've probably heard the stories where, a set of hearing aids can range anywhere from $3,000 all the way up to $7,000. And these products don't last a lifetime. So typically the individual that's hearing impaired usually will have to go back and get the hearing aids replaced every 3 to 5 years. Hearing aids don't restore somebody's hearing back to when they were as teenagers. It helps to amplify sounds. And so as somebody's hearing gets, when they're fit with these products, their hearing improves, but it also gets worse over time. So they have to go back to a provider and get readjusted for if they're currently wearing the products, or if the products are not adjustable, then they have to replace them. The other reason why people put off hearing instruments is, lastly, it's not covered by insurance. You know that Medicare Advantage plans will offer reimbursements towards hearing aids. About 92% of them do, but it's a small reimbursement. So if you're talking about a cost of $3,000 to $4,000 out of pocket, and the Medicare Advantage plan is only, let's say, covering $500 of it, well, it's still a big chunk for individuals to pick up when it comes to these devices. Let's talk about the value of offering hearing benefits. First, it can increase worker absenteeism. So if you think about in the workplace in itself, there's been a lot of studies done on workers' absenteeism. I'll pick one occupation, for example. Preschool and elementary teachers, they've done studies that suggest that 15% to 20% of the absenteeism is based on noise in the classroom. And you think about that and you say to yourself, you're scratching your head and saying, how could that be? Well, think about that the classrooms are getting larger in size. And so teachers are having noisier classrooms. And with that being said, they're having more issues with their hearing. Again, reduced workplace productivity. They've done studies that suggest that if somebody has hearing loss and are not being treated with hearing aids, it enforces the brain to work much harder than somebody with normal hearing. And so it puts more demand on the productivity of the individual. Lastly, it does reduce earning powers. So there's been studies done in our industry that suggest that somebody that's not treated with hearing loss, that has a hearing problem, they're likely to lose upwards to $30,000 annually in income versus somebody with normal hearing. When compared to people with hearing loss over a 10-year period, a study have found that people with untreated hearing loss have more health problems, increased risk of dementia, depression, and falls. And again, this is more probably falls into the plus 65 market. And if you think about falls, typically if a senior falls, what's the first thing they do? They usually go to the emergency room. And that's one of the things that healthcare organizations are really concerned of, because that's a high cost. And if somebody falls and they go into the emergency room, likely they're going to need rehabilitation, whether it's through a nursing home or some other facility. That with hearing aids, if they're fit on the individuals prior to that, the likelihood of them falling, it comes down substantially. And the reason why people fall is, part of the reason is they have equilibrium issues when it comes to their hearing. And so if they can't hear, they're more likely to have issues with their hearing. And again, they spend more time in healthcare settings. So there's more hospital stays, higher risk for being readmitted. And on average, there's been studies that done that people that are untreated with hearing aids spend more money on healthcare than people with normal hearing. And part of the reason is that if the physician says that they need to be on certain medications or do certain things, and if they don't hear that physician or don't hear the healthcare practitioner, they're likely to have, where they don't hear the instructions properly, they may have problems down the road. Again, there's early detection. So there's links between cognitive functions and early adoption of hearing aids. And so, for example, if somebody is adopting to hearing aids at an earlier age, it retrains the brain. So, for example, I'm assuming that nobody on this call is experiencing hearing loss. So, our brains adjust to certain sounds right now. So, for example, in the background at my house, I can hear the birds chirping in the background. And so my brain is adjusted not to trying to shut that down and be able to present to you right now without having that absorb me right now. But for somebody that hasn't been fit with hearing aids or has a hearing loss and it hasn't, let's say they haven't heard those birds chirp for over a decade or two, you're finally fitting them with hearing aids, it takes time to readjust the brain. And so, for them, they haven't heard those birds chirp, and it's, they're hearing that, and then they're trying to do a presentation that it causes issues with the brain itself, that it's really hard for them to adapt to hearing instruments. Secondly, it does improve the quality of life for individuals. And so, if you think about people that have, maybe in your family or friends that have not been fitted with hearing aids, think about when they are isolated, especially during COVID right now. Maybe they're afraid to pick up the phone and talk to you. Or maybe you have, like, for example, like my situation, I have parents that are elderly. My mother refuses to wear hearing aids. And so when I'm having a conversation with her and she lives long distance, it's very frustrating because she says, "What did you say? What did you say?" And then I feel like I'm having to shout through the phone several times to repeat myself. And so it can not only be frustrating from her standpoint, but for the normal hearing impaired person that's trying to have a conversation with that person, it can be frustrating as well. And again, it can improve overall health factors. And so, for example, we've done things in our industry that suggest that, if somebody does, wear hearing instruments, they're likely to, improve their overall health. They're more likely to be engaged in society. And that's really important. The current trend that is happening, that the latest devices are moving more from a basic medical instrument to a complex digital assistance, capable of carrying out tasks that are above and beyond only correcting hearing. So the big question is, how does artificial intelligence is impacting hearing aids? And I guess the big thing is it can differentiate a wide variety of noises. In other words, it can separate speech from noise. Hearing aids are also capable of tracking many health parameters, such as stair climb, steps to walk, cognitive activity. It can also be translated up to 27 different languages. So hearing aids have become much more sophisticated than maybe in prior decades. These are all digitally processed chips. So they have the option of being able to separate speech from noise. So somebody with hearing impairment put these devices in and they're trying to have a conversation with you, and let's say there's a lot of background noise that's happening. Maybe you're in a restaurant situation, there's glasses cleaning, or people are having conversations, that person that has those devices are able to kind of tune into your conversation without having all that background noise come into the hearing instruments. Again, there's been studies that have been done through J.D. Power that suggest that members, especially through health plans, want benefits such as hearing instruments, whether it's for the under or over 65 population. They feel like this is a lifestyle product that can improve their overall health. And so, again, we've done studies, and obviously in our industry, and J.D. Power has done studies that suggest that health plans are going to have to consider this as a viable benefit. I will say that, being in the industry for over 2 decades is that I've been to a number of conferences, and amazingly, when they talk about ancillary benefits and how I sum up ancillary benefits, I'm really referring to short-term, long-term disability, vision, dental, and hearing never gets a priority. Even pet insurance gets a higher priority than hearing. And so we're really low on a totem pole. But however, with that being said, I'm sure that some of you on this call are aware that, there were, with Biden's mandate or with one of the bills that he suggested, is that hearing coverage for all for Medicare was part of the initiative, and vision and dental was omitted. So he does see the value in hearing. And additionally, here in 2022, the FDA is going to give the clearance for the over-the-counter products. So you're going to see companies like Samsung, Bose, for example, that will come out with products that will provide amplification, but can also be used to stream to music, conversations, and things like that. My company, Beltone, its sister company, Jabra, which is known for headsets, probably the second most popular name behind Bose, is coming out with a product that will compete against the iPods. And so for people that just need amplification, or they get into certain environments where they can't hear the individual, they can use these products. So it's not going to be an ongoing daily product that you use day in and day out. But when you're in those environments where you just need amplification, and additionally, you can use these products to stream to music. So for example, if you're going for a run or you're working out at the gym, you'll be able to put these products in your ears and be able to stream to music. Or for example, if you're having a conversation with somebody, you can use these products. So you're going to see much more of a mainstream approach to these products to kind of get to early adapters, to get to that 20 to 40-year-old that says, you know what, I'm just going to put it off. I'm not interested in hearing products right now, but maybe down the road I'm interested. And I think that in our industry, we get a lot of those kind of concerns where people say, I know I have a problem, but I'm just not ready to address it. So, or for example, if you think about dental and vision, our minds have been, or brains, we've been told that we need to go see a dentist provider twice a year for preventative care, or for vision, go get your eyes checked. With hearing, people usually don't get their hearing checked regularly. Our industry is more of a reactive benefit. So by the time you admit and by the time you go see a provider, usually when you go and see a provider, the outcome is typically always going to be hearing aids, because you prolonged it for so long that if you had gone and seen a provider, they could at least tell you what you need to do to prevent it from getting any worse. Again, a little bit about Beltone. We're the most recognized and trusted brand. We've been in business for 80 plus years. We're based out of Chicago. Our parent company is GN, and they own several brands. They own a company based out of Minneapolis called GN Resound, as well as they own Jabra. And we're getting involved in a gaming system. And we just purchased another company called Lively, which is for people that are concerned about going to see a provider face-to-face. We have now a program placed that in an individual, if they're concerned about COVID or being able to get out to the local provider, they can actually go directly purchase the hearing aids online and then have an interaction with the audiologist through the computer and get fitted with the products. Again, we're market driven. We offer competitive pricing. So we have all brands of products from basic to advanced level technology. Typically, the individuals that are first time users of hearing aids usually prefer the basic level technology. But once they're fit with the products and they get adjusted to the products, then they usually graduate to intermediate or advanced level products. We do offer services at any of our locations. So for example, when we're working with the individual, let's say they're snowbirds, so they, reside in Massachusetts during the spring and summer months, but then they go to Florida during the winter months. We do provide services for those individuals at no cost. And again, we do provide NPS-driven quality improvement protocols. And so we measure the provider as well as the end user. And our NPS right now is at 70, which is outstanding. And so we want to ensure that the members are happy. with the care that they get from one of our providers at one of our locations. Again, from a key takeaway as I sum this up is that hearing problems are increasing. And so the demand for hearing benefits are not only for the Medicare market, but also for the commercial market as well. Again, hearing aids can provide increased income opportunity, reduce hospitalizations and acute care. And again, you can provide benefits, but I think the big thing is that to provide education. So, if you're working with groups or individuals, and, there's a lot of correlations with other health-related issues, such as diabetes. They've done studies that suggest that if you're diabetic, you're more than likely to have issues with your hearing, or you're obese, you're more likely to have problems, or smokers, or different types of occupations. That, overall, what we're looking at is trying to improve the employee productivity. And then again, lastly, it's really important to specialize with or work with partners that specializes in this. And so, there's a lot of networks that are out there to support you, whether you're offering benefits or you're looking at providing some sort of coverage for your members, whether it's individuals or small or mid-sized or large groups, that they're there to help provide cost-effective solutions for your members, so that when your members go to one of the locations, that they're able to get a maximum out of whatever benefits you're providing to help minimize their out-of-pocket expenses. And with that, I'll turn it back over, and thank you for your time.
Thank you. Thank you, Michael. Thank you for the lovely presentation and showing the social and economic impact what hearing loss has on consumers, and showing the takeaway points for the people. Thank you. Guys, any questions for Michael? In the meanwhile, we'll set up the presentation for our next presenter, Gerardo, who's founder CEO of ChartNote. His topic is, can AI medical documentation improve patient outcomes? Thank you, Michael. Thank you for the lovely
Thank you for your time.
Stay connected. Thank you for your time, and we'll stay connected. Thank you.
Thank you.
Yeah, Gerardo, hi. So,
hey, good morning, Ethan.
Good morning. Hope you are doing well. So,
let me know what I need to do.
Yeah, so you have to share the screen.
Okay. Let's see.
Yeah. It's coming perfectly well.
Oops. Let me just make sure I can. Okay. Perfect. So, good morning, or maybe good afternoon for some of you. My name is Gerardo. I'm the founder and CEO of ChartNote, and I'm also a family medicine physician and hospitalist. I'm passionate about efficient medical documentation and empowering clinicians with technology. ChartNote is a tool for clinicians to expedite their medical documentation, and we partner with Ognido to provide next generation AI voice recognition. And today I want to start by exploring how medical documentation affects clinicians and patients, and then discuss some of the current and future tools that can help with it. Last year in the US, there was more than 30% increase in investments from AI health sector. It jumped from $6 billion to $8 billion in 2021. And investors recognize the enormous potential that AI solutions can offer to improve every aspect of healthcare, from patient care to cost reduction by reducing process inefficiencies. And this is paired with an explosion of data coming not only from EHRs, but also from patients themselves through consumer wearables and health apps. An average of 250 health apps are released every day. And currently there are over 350,000 health apps. And when healthcare transitioned from paper charts to EHRs, the burden of medical documentation for clinicians increased. These legacy EHR systems are good tools for reading and writing data, but they don't have the reliability and availability that some of the big tech companies, platforms like Google or Amazon have. EHRs come way behind these platforms when it comes to user friendliness or consumer experience. So will AI solve the burden of overwork and burnout clinicians? AI has the potential to decrease the administrative waste caused by charting and freeing up clinicians' times to focus on the patient. And even before the COVID pandemic, there was almost half of the U.S. Physicians in the U.S. reported feelings of burnout. And because of COVID, burnout is now more common among intensivists, where COVID patients are the most sick. But historically, clinicians that work in primary care specialties are the most affected. And these include family medicine, like myself, obstetrics and gynecology, internal medicine, and pediatrics. And coming up with solutions that address physician burnout is very important, because burnout can lead to depression and even suicide. In the US, the prevalence of depression among physicians is 2 times higher compared to the general population. And on average, a physician commits suicide every day in the US. So there are many contributors to physician burnout, but the main causes is medical documentation. Entering data into EHRs is time consuming and shifts the focus from patient care to administrative tasks. And clinicians have become professional data entry clerks, and it prevents them from practicing at the top of their license. So during an average office day, physicians spend about 2 hours of EHR and desk work for every hour of direct clinical face time with patients. And outside of office hours, physicians spend another 1 to 2 hours of personal time each night doing additional computer and other clerical work. So why is the patient not the primary focus of attention during a typical office visit? So to have a better understanding of what medical documentation entails, let's dissect the process of charting. First of all, the average office visit in primary care list, it lasts about 20 minutes. Of those 20 minutes, more than 3/4 of them, the doctor is interacting with the EHR, about 60 minutes. And then a third of this EHR time is spent pre-charting, which means reviewing the chart and trying to understand what's going on with the patient in front of them. And it can be reviewing previous visit notes or notes from other doctors, lab results, etc. And then almost 1/4 of this EHR time is spent on actual documentation, writing the note and entering other data like diagnosis and billing codes. And once the doctor has an assessment of the problem being addressed during the visit and has a treatment plan, the remaining of the time is spent placing orders on the EHR. So as you can see, primary care clinicians spend more time data mining and finding information than writing the note itself. So even before EHRs were fully adopted, physicians relied on third parties to complete their medical documentation, from staff to transcription services. While medical transcriptionists are not mainstream any longer, medical scribes are popular. Almost 20% of physicians in the US use scribes. And nowadays, speech recognition is even more popular. More than 60% of physicians in the US use this tool to dictate their notes. Another low-tech tool to expedite medical documentation is the use of problem-oriented templates. They not only decrease charting time, but also improve the quality of the note. Using scribes and transcription services is not only expensive, but they both have their unique set of limitations. They're both labor-intensive and are hard to scale. Transcription turnaround time for completed notes can take up to 24 hours, And onboarding a scribe is time consuming, and these positions have high rates of turnover, making the quality and consistency of the service unreliable at times. And dictating a note using speech recognition has many advantages. The advantage of dictating versus typing a note using a keyboard is significant. A physician on average can type 35 words per minute. On the other hand, speech recognition software can easily transcribe over 150 words per minute. And AI has had a tremendous impact on the accuracy and quality of speech recognition by leveraging deep learning to achieve voice to text and include some natural language understanding. This next generation voice recognition has the ability to detect intent. It can understand voice commands from the user. And this very high level natural language processing task allows these tools to be sort of an assistant to the doctor, using speech recognition and artificial intelligence to populate a note in the EHR using the physician's voice without navigating the EHR user interface. Many companies are now offering solutions that use deep learning NLP. However, most of them still require a human in the loop to assure quality of medical documentation. Ambient clinical intelligence is what the future of AI in medical documentation will be. The goal is to remove the keyboard and the mouse from the doctor-patient interaction. Ambient clinical intelligence captures a multi-party conversation and creates a clinical documentation automatically by using text summarization. The white papers from this company suffering these tools show more than a 50% reduction in documentation time and physician burnout. And these are obviously the result of small studies, but there is real potential in this elegant solution. So the nuances of facial expression, body language, and other nonverbal cues are aspects of clinical patient conversation that cannot be captured by ambient listening. And this is assuming that the patient actually speaks English. Not everything that transpires in a visit needs to be documented. For example, if a doctor tells a joke to the patient, obviously that's not part of the note. And ambient clinical intelligence will still need some cues from the clinician to flag what's relevant and somehow get the whole assessment and plan that the clinician is thinking in his head and didn't communicate to the patient. Sometimes because there's a lot of jargon in it or for some other reason. And so these are some of the limitations that ambient clinical intelligence has. The environment itself can be a barrier. Trying to capture audio in a busy emergency room can be a nightmare. And a key challenge to this innovation also is the willingness and infrastructure of EHR companies to support integrating with third-party applications. Traditionally, EHRs are well known for limiting innovation with their restrictive interoperability. And although EHR's connections with outside systems have improved, there are different levels of interoperability. The basic level is foundational, where a completed note can be delivered into the EHR, but a structural integration where discrete data elements can be exchanged is needed so that the AI assistants can pull out patient context and complete an actual task. So for example, a doctor could give a voice command to send a prescription or order a lab, and this can save precious time during the visit and enhance the doctor-patient interaction. A study on EHR usability showed that it can take up to 62 clicks for a doctor to place a simple order of Tylenol. So what are the three main goals of medical documentation? One is to support continuity of care. The second one is billing. We need those ICD-10 codes, EM, and CPT codes. And if it's not documented, it didn't happen, and you don't get paid. The third one is to cover our behind. And Medicare, with their Patients Over Paperwork initiative, updated their office visit coding guidelines last year to make them simpler and more flexible. Changes included eliminating history and physical exam as elements for code selection. So now you only take into account the assessment and plan what the actual thought process of the doctor was. So a key change in the guidelines is that now ancillary staff or the patient itself can record the chief complaint or the HPI or the history of present illness. So the patient could complete a questionnaire and then the answers could become part of the note. So this opens up the possibilities. You could use an electronic form with questions from the patient to fill out prior to the visit. But what if instead of a simple form, we use AI conversational agents to collect patient information? And they can be text-based like a chatbot or voice-based. Almost everyone has a smartphone these days, and up to 35% of Americans use some sort of smart speaker on a daily basis. And of course, there are some limitations with this. Alexa not always understands what we want, and we have to repeat ourselves. But NLP is advancing rapidly. Another aspect of medical documentation where AI is having an impact is using NLP to analyze unstructured medical text from a note and automatically extract information like medications or medical conditions. When we link these entities to medical ontologies, we can suggest actionable insights to the clinician. And these insights can support clinical decision making and improve patient care. By analyzing and extracting meaning from the clinical notes, we can automate content population in the EHR, for example, ICD-10 codes, and this can have a great impact on the revenue cycle. Ultimately, the goal is that AI can help clinicians with all these administrative burdens so that they can focus on the patient and improve their experience. AI is transforming healthcare and is giving us the chance to reimagine medical documentation because medical notes by themselves don't provide healthcare. It's actually humans that do. Thank you for your time, and I'm open for any questions. I can't hear you.
Thank you, Gerardo. Thank you. Sorry, there was a technical one. Yeah.
Okay.
So thank you for your lovely presentation, and hope everyone enjoyed your talk. I thoroughly enjoyed it, and love to have your comments from anyone. Anybody who wants to ask any question, you can just type in the chat box. We are exactly on time, because after this, there will be the last presentation for this half-day virtual event. Hope you all guys are liking it and enjoying from the quality speakers who are present today. So we'll just take 1 minute. In the meanwhile, we'll set up the last presentation for the day by Reni Dua, who is the Chief Strategy Officer. Hey, Reni. Making artificial intelligence work for real patients. Reni, are you there? Yeah.
Hi,
sure.
Nitin. Hi there. Are you able to share my slides, please?
Yeah.
I don't see my slides.
We are setting up, Rennie. We'll
No
just
worries.
give us
No
some
worries.
time. And in the meanwhile, you can introduce yourself to the audience so that
Sure.
people are aware of
Sure.
you, and then we'll start. Yeah.
Sure. Yeah, that's my very first slide.
Okay. Sure.
So if acceptable, I'll just wait.
Able to see the screen?
No. Yes, it is coming now. Rennie, are you there?
I sure am.
Yep. So your presentation is appearing now.
Yes, it is. I just won't be able to control it yet.
Yeah. Yes, it's visible. You can start, Rennie.
Perfect. Thank you so much. But you will have to move the slides for me. I
Yes,
cannot
yes, sure,
control.
sure.
All right. Many thanks. Well, thank you so much. There's a reason I always opt to be a chief medical officer or a strategy officer. I'm clearly not great with IT support, so thank you, Arvind, for helping me with that. It's great to be here. As Nathan kindly introduced me, my name is Renee Dua. I am the former founder, I am the founder and former chief medical officer of a company called Heal, and I am the founder and chief strategy officer of a company called Hey Renee. And it's a real privilege to be spending time with you and talking to you a little bit about the way I see intelligence growing in the health tech community. A little intro about me. I am a kidney doctor by training. I've been in private practice for about 17 years, in addition to the startups I founded. I am the daughter of two doctors who are both immigrants from India. And they came to this country many, many years ago and impressed upon me the importance of service. And to this day, if you talk to my parents, they will tell you that their biggest responsibility has not just been the growth of their children, but also the success of their patients. They both practice to this day. And it was such a huge part of my upbringing, the importance of service in the medical community, that I too went on to become a doctor, which has been the joy of my life. The greatest privilege is to be able to care for my patients. But about 7 or 8 years ago, I became a patient too. And it really changed my thinking on the doctor-patient relationship, which I'm almost embarrassed to say. Certainly, I was a compassionate person and I felt very much a responsibility to my patients. But what I didn't recognize was how convoluted and confused my life as a patient would become, and certainly how much it would impact me, my husband, and my children. And that really happened for me as a mother. As a mother, I started Heal, and that was when the entrepreneurial light bulb turned on for me. And I'd love to share with you how becoming a mother led me to become an entrepreneur, right? The entrepreneur of the home is the mom. And it really led me to understand patients differently as a doctor. Next slide, please. Heal was born 7 years ago. I genuinely consider it one of my babies. And what we aimed to do before a pandemic was create a software platform that would deliver primary care in the home. We not only did house calls, but while we got there, we enjoyed a relationship with our patients where we set up remote monitoring devices, we set them up on video telemedicine, and we saw the circumstances in which they lived in the home, which, as we all recognize, certainly during the pandemic and the explosion of health tech that's delivering care in the home, how relevant the house is to understand a patient's surroundings, their capabilities, and to build compassion and understanding. When we were in the home, what we realized was we were building a different intimacy with patients. And we started Heal as a cash pay service, honestly, to build and prove a concept. But the single first interaction I ever had with the intelligence community and building intelligence in health tech was real-time eligibility for patients. So in other words, they downloaded the Heal app and they were able to input their credit card and their insurance card, their health insurance card. And immediately we were able to tell them what that visit would cost them. Typically, it would cost them the same amount of money would it be that they went to the doctor's office. So of course we afforded them an unbelievable transparency to what they were owed, what we were owed, and what they were going to be charged. And to this day, we never send a statement to a patient that uses the Heal app to get care in the home. And this is because of that real-time eligibility experience. That very experience, again, based on intelligence, allowed us to become a trustworthy partner to patients. And when we built trust, we were able to deliver, as you can see here, hundreds of thousands of house calls, and actually deliver an excellent experience that patients enjoyed, all the while seeing their surroundings and commenting on those very social determinants of health that were preventing them from getting excellence in care before. Next slide, please. In my mind, and it's always been my focus, I've set my career on delivering care to the underserved. And what I think many of us in the health tech community are coming to understand, it's that patients, especially underserved patients, are being left out of certainly health tech, but many basic healthcare decisions made by hospitals, made by health insurances, and risk-based entities. And coordination for these people is king. We have to develop a fabric that creates convenience for those members of our community that are being left behind. What COVID has done is, of course, driven millions and billions at this point of dollars into health tech. But what it's also shone a lot light on is how many people are being left behind. And just now you're seeing support for the Medicare Advantage and Medicaid communities, which I think is wonderful. But the success for these patients is not just developing an annual wellness visit for them and having them go. The success is getting there and carrying out the very tasks that need to be done based on the results of that health risk assessment or that annual wellness visit. And the way to do this, again, how do we coordinate? We first build trust. We first show compassion. When we show compassion, we then are including patients, especially those that need us most, and we're building on a consolidated experience. At the Hey Renee platform, for example, we are doing this step by step, patient by patient, and we are literally delivering a concierge experience to patients who need our help the most. Next slide, please. Why is it that every other industry at the moment is focused on the next world, building a metaverse using intelligence? And here we are in health tech, still on planet Earth, cumbersome and confused as ever. I find this fascinating, that everyone else is focused on gaming and technology for the sake of technology and in Bitcoin. And here in health tech, we are just at an infancy of figuring out how to solve problems for real people. And I think there's a few answers to this question. And unfortunately, I think it's because many of us might be going about problem solving the wrong way. And you don't need to look very far. You can see the evidence of how COVID has affected patients most in need, who are underserved, who are in communities where members of health insurance may not be engaged and are frankly being forgotten. You can also take a great look at the stock exchange, right? And you can see, caps of companies crashing. And I think what we have to do, once again, is step back and look at what health tech is doing, and are we building real businesses? Right now, in my estimation, what I see is quite a few single point solutions, right? Mental health is a critical problem, certainly during the pandemic, but it turns out that many diabetics and many people with chronic illness also have mental health. And we cannot expect certainly vulnerable populations like the elderly to log into 12 apps to get solutions to remember to take medications, to see their therapist, to check their blood sugars and blood pressures. It won't happen for them. And thus we are disconnecting their care further. There's also, of course, we can read in the news every day, serious concerns regarding pricing models and RAF scores and medical expense ratios and upcoding. And we have seen consistently that some of our largest payer colleagues are paying massive fines because of information gathering and data aggregation that is not factual, right? And so these problems are creating what I like to call, unfortunately, skimming off the top. Next slide, please. The other very serious problem, and Gerardo began speaking about it in his really awesome presentation, is that at this point, 60% of physician practices are owned by payers. And what this means is that there is a top-down approach to tell a doctor how to practice care. And of course, those incentives to make a doctor do something are perverse. The business of being a doctor is an art. We sit with patients, we spend time with them, we develop an incredibly intimate relationship with our patients, and we need to do what is best for our patients, and we need to have tools that help us with decision support. We cannot spend time clicking 60 buttons to order Tylenol, as Gerardo had pointed out, which is so alarming and a real experience I myself have in my own private practice. So we want our doctors to become independent thinkers of what is good for patients. And I would challenge any risk-bearing entity, any administrator who is telling a doctor how to practice medicine to go have a seat in that doctor's office, especially in the middle of a pandemic, and see the myriad issues that come across their desk while they are trying to do the right thing. Scheduling issues, missed appointments, severely aggressive patients, charting all those risk factors and care gaps that need to be closed, ordering all those medications, building that care plan and task list. It is an unbelievable ask of doctors, and frankly, as well, nurses and medical assistants and those support staff that are leaving this field in droves, which is not good for the health tech community. We are still reliant on human beings to help us care for patients. Next slide, please. In other words, what I've developed for you is there's a lot of noise in our space, and maybe why we are not yet, and certainly nowhere close to developing our own metaverse, right? We need to remain here on planet Earth, and certainly I can comment in the United States, and focus on the fact that our patients are being disengaged and they are not able to use all services together in one place, which makes them apprehensive. What's in it for them? What are we doing for them? And I submit to all of you, when you take excellent care of patients, you will always be rich. The best thing we can do for our patients is engage them by giving them the tools they need to feel connected to us as providers of care. Next slide, please. To build intelligence, therefore, we need to step back and build compassion. And when we build compassion, we build trust. And when we build trust, we are able to look at our patients more comprehensively because they will share more, right? They will let us in on more of the frustrations. We will then be able to develop that fabric of conveniences to get our patients over this last mile problem, to get them where we need where they need to go. And from there, we are building what I like to call a symphony, right? All the parts of an orchestra coming together to play a beautiful piece of music that looks like a patient that is aging at home with dignity and not worrying about how to get well, but rather how to stay well. Next slide, please. As I had mentioned before, we who are in the health tech community, we need to look at what services we are providing for patients and providers of care, whether they be doctors or hospitals or insurance systems. And those very systems of tech, whether they be, again, diagnostic or supportive and enabling, they need to assist us doctors, us insurance companies, us hospitals on how to make decisions that are in the patient's interest. Only when we are doing that are we delivering on excellence in care, are we delivering intelligence, and are we delivering and improving outcomes. Next slide, please. And so, again, rather than have a reactive approach, we will have real, true primary care, the kind of primary care that both handles urgent problems, handles comprehensive problems. Like I said, there is no health without mental health, for example, looks at remote monitoring and uses it as a tool for engagement and as a tool to prevent hospitalizations or emergency room visits, and thus allows a patient to engage proactively and look at her values and look at her mental health and say, here are the steps I need to take so that I don't have to be worried, or I don't have to worry my caretaker, I don't have to use the hospital setting. And ultimately, all of these tools will come together in this symphony I describe of predictive and intelligent care. Next slide, please. Again, I submit to you, friends, that we are humans, not necessarily consumers, but humans, and we will all be patients. And as patients, we need to remember that without compassion, there can be no intelligence to care for us. I thank you so much for the opportunity to be here with you, and I'm excited to hear your questions.
Thank you. Thank you, Rennie. Thank you for the lovely presentation and giving a sweet and crisp insight into how we can help with the patients. Thank you.
Thanks so much, Nathan. Thank you.
Thank you. Guys, any questions to Rennie before we wrap up the day for you? From Adriana, there's a good thing about you, Rennie. You are spot on. Great perspective.
Thank you so much. Thank you for being here and listening.
How did you get over any difficulties for patients who may not have the access?
Well, I'm not over it. I work on it every hour of every day. That's my job. It's why I still go to my office and see patients. It's why I remained an advisor for Heal, so I could be of any service as the company is growing. And it's why I started Hey Renee, where, you know, literally my husband, who's the CEO of the company, Nick Desai, named the company for me, because every person, every patient deserves a daughter who happens to be a caretaker and a doctor delivering on accessibility and helping. This company was born out of my own experience taking care of my dad. And while my dad doesn't per se have access issues, it's amazing how many things were just difficult for the sake of being difficult. So it's not a problem I'm over. It's something I work on constantly and I think about all the time. And I welcome any advice from any of you out there who think I could be doing things differently in my own companies.
Thank you. Thank you, Rennie. Let me see if any other question. I think it is the last one. Thank you, Rennie. Thank you for the lovely presentation. We'll stay connected. Have a lovely day ahead. Yeah, thank you. And a lovely weekend as well. So, guys, just to wrap up, we'd like to thank our technology partner, Digit7, and all our community partners, speakers, and attendees who came together for enriching knowledge through this forum. We had a great set of speakers who came today to share thoughts, and there are 6 in numbers, along with a great panel discussion which we have witnessed today, moderated by Chitrai Mani, who's the CTIO of InfoVision. Just for your information, today's event was broadcasted in the YouTube and Facebook page of our company. So you all can go there and see the recording anytime. Please log on to our website, the social media channels. We'll be sharing lots of knowledge sharing topics, details, announcement of next events, and much more, which will help you register and attend the same. Just to remind you, there is another webinar coming this month on January 25th, themed around the same thing, AI, how AI and robotics are transforming the future of healthcare. We'll send the details of the event along with the joining link to everyone who have registered. So do not attempt to miss that same too. There are a lot more in store for subsequent months as well, with focus on banking and financial industry, retail, e-commerce, supply chain, aviation industry, and much more. So request all of you to stay connected with us, enjoy the learning. Thanks, and do take good care of yourself. Bye. Thank you.